dersler, bilimsel çalışmalar, ondan sonra bir araya gelmeler, tanışmalar, dolu dolu bir kongre geçiriyoruz. Ben 2 dakika, 5 dakika mekanik ventilasyon kursundan buraya indim. Şimdi buraya gideceğiz. Diğer arkadaşlar da koşturuyor. Eğitim alıyorlar, geliyorlar, gidiyorlar. Bu konuda çok mutlu olduğumuzu söyleyeyim. Tabii bazı arkadaşlar daha çok katkı veriyor. O da gözümüzden kaçışmıyor. Buralarda biz mümkün olduğunca hem insanların böyle acil tıp konusuna ne kadar katkı verebildiklerini görüyoruz. Hem de böyle tanışma fırsatı oluyor hem arkadaşlarla. O yüzden bugünümüzü de iyi geçireceğimizi umuyoruz. Kongrenin bir diğer uydu sempozyumuna başlayacağız arkadaşlar. Burada aslında gerçek acillerde çok önemli bir yer kaplayan kardiyolojik aciller ve bunun için herhalde acil servislerde en çok başvurduğumuz, hemen her hastada başvurmak zorunda olduğumuz ve giderek de daha yaygınlaşan EKG kullanımı. Herhalde acil servislerde en çok bir glikoz ölçümü var, bir EKG çekiliyor, değil mi? En çok başımızda olan iki şey bunlar. Çünkü bu ikisi de atlama lüksümüz yok. Zamanla yarışımız var ve geri dönüşümü kötü oluyor. Ama özellikle akut koroner sendrom ve EKG'nin değerlendirilmesi çok farklı bir süreç. Hani kongre boyunca biliyorsunuz aslında hemen her kıtadan, her dilden katılımcılarımız var. Sabahleyin gelmeyenler olmuş olabilir. Çin'den bağlantı vardı. Hatta o kadar merak ettim ki ya sonunda teşekkür ederim yazmış ama o kadar uzun ki. Yanımda da araya vardı. Ya bu o da Çince biliyor. Dedim ki ya buraya bir merhaba yazsana, ne kadar sürüyor bunu yazmak. Baktım ya hemen yazdılar. O bize karışık falan gelen şeyler var ya, öğrenince oluyormuş. Bu EKG'nin de arkadaşlar bir dili var. Öğrenmemiz gereken. Yani bir yabancı dil gibi bu. Ve bu EKG'yi öğrenmek var ya, gerçekten insanda çok farklı yani süreçler oluyor. Yani çok farklı süreçlerle öğrenebiliyorsunuz. Biliyorsunuz yıl boyunca mesela EKG'de çok farklı formülasyonları eğitimlerde yine C ile beraber gündemimize getirmiştik. Şimdi oransal şeyler çok önem kazanmaya başladı. Bu konuda da bir taraftan Amelmatu, bir taraftan Doktor Smith çok ciddi üzerine çalışıyorlar. EKG'nin matematiksel oranları. Şimdi Mehmet hocamız, çok değerli dekanımız, bu konularda bizi bilgilendirecek ama hocam önce şöyle acil servislerin bir resmini de çizmek istiyorum. En çok sıkıntı duyduğumuz noktaların başında maalesef en gelişmiş şehirlerimizde bile hastanın eski EKG kayıtlarına ulaşamamak gibi bir sorunla karşı karşıya kalıyoruz. Bu dijital ortamlarda mutlaka bu EKG değişikliklerini bilmemiz lazım. Eski, yeni. Mesela atrial fibrilasyonda ne diyoruz? Tedavi akut veya kronik olduğuna göre diyor. Peki akut mu kronik mi nereden anlayacağız? Eski EKG. Nerede bu eski EKG? Yok. Başka bu soruyu nerede soruyoruz? Malpraktis davalarında. EKG çekmiş miydin? Çekmiştim. Nerede bu EKG? Arşivde dosya. Bulabilirsen bul. Başkasının EKG'sini koyacak halimiz yok yani. Dosya çok kötü. Bulamıyorsun. Yani bu yüzden çağımızda dijital devrimde EKG'nin de dijitalleşmesinin bize çok önemli katkıları olacak. Bir taraftan ulaşım, bir taraftan da tanı. Tanıda da bu dijital EKG'nin çok kolaylaştırıcı özellikleri var. Onları da tartışmaya vaktimiz olur umarım. Bu konuları bize anlatması için yıllardır benim yanımda gördüğünüz, hep ikimizin beraber yürüdüğünü müşahede ettiğiniz çok değerli dekanımız, aslında rektörümüz de neyse şimdilik dekanımız diyoruz. Profesör Doktor Mehmet Gül'ü sahneye davet ediyorum.
kulaklığım var ama önce bir Sayın Başkanımıza selamlayayım, ondan sonra aşağı inerim. Herkese günaydın, hoş geldiniz değerli arkadaşlar. Gerçekten Sayın Başkanımızın o iltifatlarına ne kadar mazharız bilmiyorum ama Sayın Başkanımız bu dijital EKG ile ilgili, EKG'nin önemiyle ilgili girişteki çok değerli katkılar nedeniyle öncelikle kendisine çok teşekkür ederim. Ayrıca Özel Medikal'e de bu EKG vesilesiyle arkadaşlarımızla bu konuyu güncel bir şekilde tartışma fırsatı verdiği için de ayrıca teşekkür ederim. Gerçekten şu otururken ismime bakarken bir konuyu da sizinle böyle bir hani sizin de fikrinizi almak isterim. Başta başkanımız olmak üzere. Doğru mu yanlış mı ne yaptığımı ben de bilmiyorum da görev olarak resmi görevim Necmettin Erbakan Üniversitesi Konya'da. Ama şu an görevimiz Aksaray Üniversitesi olduğu için Aksaray diye yazdım ama burada bir nezaketsizlik ya da yanlış bir şey yapmış olmayalım. Doyduğumuz yer diyoruz ama onu da böyle bir...
Hocam acizane teklifin bütün ünvanlarını her zaman yazacağım. Her zaman.
Tamam. Evet. Şimdi şurada şey var mı? Aşağı ineceğim ama şu mu? İleri geri.
Sonraki sayfa. Önce...
Teşekkürler. Şimdi şöyle bir salona bir soru soralım. Hangi çağda yaşıyoruz arkadaşlar? Şimdi bir önceki sunum, ben de yan salondan geldim. Başkanımızın dediği gibi o oturum yani herhalde bizi şey gördü hocam, genç gördü. O salondan bu salona koşturuyoruz yani. Orada da dijital teknolojiyle ilgili bir sunum vardı. Genç bir moderatör arkadaşımız bizimle biraz ne derler? Alay etti demeyelim de takılmak istedi bize. Ben de bu yaşlıların bir özelliği var. Geçmişi iyi hatırlar dedim. Yani birkaç yıldır bildiği konuda bize şey yapacakken ben 15 yıl önce o konuyla ilgili sunum yaptığımı hatırlattım ona. Böyle bir şeyimiz oldu aramızda. Şimdi hangi çağda yaşıyoruz? Bir penaltı atayım mı? Çağımız sen sus gözlerin konuşsun. Uzay çağı diyenler var mı? Şimdi bu hep tarihi tabii şeylerle, çağlarla anılır. Eski çağ, orta çağ falan derken son zamanlarda artık biraz daha teknoloji, dijital ne bileyim işte bu yapay zeka vesaire, bilgi çağı gibi ve biraz da sıklaştı. Artık eskisi gibi savaşlarla bir takım yerleri elde ederek çağlar açılıp kapanmıyor. Artık bilgilerle gidiyor bu işler. Bu tabii uzay çağı değiliz. Ama bu ne? Bunda şimdi Sayın Başkanımız der ki, çok her zaman zikreder. Bir şehri görmek için en yukarıya çıkmanız lazım, en iyi görmek için diye. Ben de Aksaray'a gittim. Acaba Aksaray'ı en iyi nasıl görürüm diye. Bilen var mı Aksaray'ı en nasıl iyi görülür? Aksaray'da çalışanlar var. Şerife ne diyorsun? Aksaray'ı en iyi nasıl görürsün? Nereden? Hasan Dağı'ndan. Bravo. Ben de öyle yaptım. Ama fazla çıkmışız herhalde. Şu benim yani. Şimdi EKG tabii gerçekten tabiri caizse Sayın Başkanımızın da dediği gibi mütemmim cüzümüz, yani her yerde taşıyoruz, taşımamız lazım. En azından başımızı belaya sokmaması için çok değişik hikayeler yaşadık bu EKG ile ilgili geçmişte. Çok değişik bir hocamız vardı, kardiyolog, bizim asistanlık dönemi öğrenci, benim de hocam, şimdi emekli oldu. Onun bir EKG, hep gözümün önüne o gelir EKG deyince. Bu değil tabii, böyle daha ince şeritli EKG'ler vardı. Ardışık EKG'ler tabii, o zaman bir de iç hastalıkları kökenli bir kardiyologtu. Sürekli böyle EKG, işte o biraz da böyle çok ne derler, bağışlasın beni, biraz paspal böyle şeyi vardı. Hocam hatırladı. Böyle EKG'ler birbirine karışmış, birisi uzun, biri kısa, böyle karışıklar. Adam değerlendiriyor ama ya diyeyim ben, hakikaten neyi değerlendiriyor acaba burada? Bir şey görüyor mu, görmüyor mu? Merak ederdim yani hakikaten. Yani o süreçlerde, o karmaşada, o tabii hep yaşadık, hepimizin yaşadığı. Özellikle bizim jenerasyon ve sonrakiler. Yeni arkadaşlar belki o kadar değil. Ama klasik biliyorsunuz, Eindhoven bu. 1895 yılında Hollandalı PSV, Eindhoven'dan hatırlayın. İlk kaydı işte galvanometre ile ve nihayetinde tabii, değil mi? İnsanlar böyle bir buluşlar yapıyorsa çok değerli, çok önemli. Bunun da bir taşlanması gerekir, değil mi? Şu muydu? Pardon. Ve buna istinaden de değil mi? Kendisi Nobel ödülünü alıyor. Tabii bu bir süreci var. Deneysel süreçlerden işte neydi? Kaplumbağalardan başlayan ve daha sonra insanda çok daha primitif bir makine üzerinden icat edilmiş ve daha sonra günümüze doğru gelen bir EKG. Bu EKG'leri kullanan var mı aramızda? Bayağı genç bir ekiple karşı karşıyayız zaman. Yani bunlardan hiç kullanan yok mu? Tamam, bu ilk EKG gördüğünüz gibi çalışmıyor mu? Değil mi? 1965'te kullanılan bir EKG bu. Daha sonra tarihsel süreç içerisinde günümüzde kullandığımız, yaygın olarak kullandığımız EKG cihazlarımız. Şimdi tabii burada EKG sadece acil serviste değil. Şöyle bir şey aklıma geldi Sayın Başkanım. Siz konuşurken böyle şey yaptı. Çok onu da bu şeyle yad etmiş olalım. Yakın zamandaki bu Amasra'daki Grizu faciası nedeniyle ölenlere başsağlığı, kalanlara sağlık, şifa, sabır diliyorum. Orada hakikaten bildiğimiz tabii birçok yerde, daha çok böyle uçak kazalarında falan, değil mi? Kara kutu olayı. Orada da aynı şey. Çok şeyi çözüyor. Yani insanda artık bu teknolojiyle diyorum ki ya an be an hiç şeysiz, boşluksuz bir şekilde vücudumuza devam eden birçok şey var ama metabolizma anlamda. Ama hep böyle bir şey her an sürekli olan bir şey ne? Kalp çalışması, değil mi? Kalp. Kalbin elektriksel faaliyetleri. Tamam, orada güzel bir şey var. Bizim için kara kutu demeyeyim de. Bunun işte tam da belki sürecin bir aşaması mı diyeyim? İşte bu dijital EKG. Yani mümkünse hastanın ilk değerlendirmesi, tabii ilk değerlendirme diyoruz ama tabii o Sayın Başkanım dediği gibi başkasının EKG'sini kullanmama demişti ama biz başkasının EKG'sini kullandığımız şeyleri de parantez içerisinde ve bir tırnak içinde size sunuyorum. Yani özellikle son EKG, son değerlendirme. Şimdi aritmilerin tespiti, iskemik kalp hastalığı ve diğer şeyler açısından EKG'nin çok değerli bir yanı var. Başlıca önemli yanları acille ilgili. Geleneksel EKG kullanımını dediğim gibi bunu yaşayanlar hani aynı anda belki önceleri biraz daha kardiyak hastalara yönelik yaptığımız bir tetkik gibiydi ama şu son zamanlarda özellikle neredeyse her hastaya EKG çekiyoruz, değil mi? Yani elektrolit bozukluğu, toksikoloji bilmem ne bir sürü olaylarda EKG çekiyoruz. Hocamın da dediği gibi EKG aslında çok aslında göründüğünden çok daha fazla bize değerli bilgiler verebilecek ve işte o ile şeyi sağlayabilecek yeni teknoloji EKG'lerle sağlanabilecek bir altyapı. Bu eski EKG'lerde bunları görmek mümkün değil. Yani spot kaybolma riski çok yüksek. Maliyeti çok fazla. Bakın maliyet özellikle son yıllarda hepimizin gündeminde. Yani bir araya gelsek yöneticilerle olsa her yerde maliyet, cost. Yani biz bunu yine bununla ilgili de ilginç bir şey Sayın Başkanım hatırlayacaktır. Acil serviste cost efektivite ile ilgili de belki 20 yıl önce bir sunum şey yapmıştık. Yani o zamanlar performans sistemi şu buyu daha yokken ama günümüzde hele daha da artarak hatta maliyet çok önemli, çok değerli. Yani kimse hani o kadar zengin değil. Dolayısıyla arşive ulaşım Sayın Başkanımın söylediği gibi. Yani zamanla yarışıyorsunuz. Her şey artık eskisi gibi çok daha böyle kompakt kısa ortamlarda değil, geniş alanlar var ve bir karmaşa var. Ve bu hastaların işte önceki EKG verilerine ulaşmak, termal kayıt maliyeti, arşive ulaşmak dedik. Bunları hakikaten ciddi güçlükler. Tabii dijitalleşme herhalde şu son zamanlarda hepimizin sıkça telaffuz ettiği, aslında ufak tefek de böyle kavram karışıklığı olan bir kelime. dijital işte analoğun dijitale dönüştürülmesi. Bir sadece veriden ibaret. Başkanım hocam Amerika'ya ne zaman gitmiştiniz en son? Kaç yıl oldu?
Beraber mi?
Yok. Beraber gittiniz. Sizin yalnız gittiniz. 10 yıl oldu mu? Daha fazla belki.
Olmamıştır o kadar.
O zamanlar hakikaten Amerikalılarla ilgili bir şey söylemişti. Hep kayıt yapıyorlar sürekli. An be an kayıt içerisindeler diye. Tabii o verilerin işlenmesi, adaptasyon süreci, sahaya yansıtılması, uygulanabilirliği, verimliliği, integrasyonu vesaire. Bunun artık son şeyi işte dijital dönüşüm dediğimiz sistemin oluşturulması. Tabii bu sistem dijital dönüşümü tamamlanmış bir EKG kullanımının avantajlarını iyi bilmemiz lazım ki bu konuda bir afinitemiz olsun. Yani otomatikleştirilmiş bir iş akışı kullanıcının süreçle etkileşimini azaltıyor. HBS sistemi artık gerçekten ülkemiz yazılım noktasında, bu otomasyon noktasında, ülkenin tüm yurt satına yayılması noktasında iyi bir yerdeyiz. Bunu gururla ve söyleyebiliriz. Hakikaten özellikle sağlık bakımından bunu son Covid sürecinde de hepimiz nihayetinde gözlemlemiş olduk. Bu HBS üstünden kayıt istek oluşturulan hasta bilgisi dijital olarak EKG yönetim sistemine girmesi, bu cihazın tek hareketle tüm hasta demografik bilgilerini indirmesi HBS'ten, yine çekim işleminin yapılıp dijital olarak EKG yönetim sistemine girmesi, bu yönetim sisteminden EKG verisinin hastane içerisindeki istediğimiz her yerden, bu çok son derece önemli bir şey. Bakın şimdi konsültasyonlar yapıyoruz acil serviste, çok farklı bölümlerle, belki de her bölümle konsültasyon yapıyoruz. Bu EKG çok değerli, çok komplike, çok ifade etmesine rağmen birçok bölüm tarafından acil ve kardiyoloji dışında çok nadir değerlendirilebilen bir tanısal yöntem. Doğru mu? Dolayısıyla bu EKG yüzünden birçok zaman kaybına, yani hastayı nerede nasıl ulaşacak ama çok rahat ulaşılabilir bir şey olsa, o konsültasyonda EKG değerlendirmesini yapacak hekim çok daha rahat bir şekilde ulaşılabilir. Yine teşhis tedavi süreci zaman kazanılır, karar süreci hızlanır, güvenli bir çekim sağlanması, kayıtlara her noktadan erişim sayısı gibi sebeplerle üretkenlik artar ve bu daha da gelişmiş tanısal araçları kullanmamıza olanak sağlar. Peki bu daha da önemlisi, hocam yine az önce söylediği iki isimden dünya çapında bu konuda otör, değil mi? Hepimizin bildiği Amal Mattu, EKG'nin matematiksel olarak, yani birçok hakikaten çok değişik ölçümlerle, çok değişik analizlerle EKG'deki bir takım bulgularla çok farklı tanılarla gidebileceğimizin önünü açacak güzel bir fırsat gerçekten. Burada gördüğünüz gibi işte PR, QRST, QT gibi intervallerin ölçümü, ölçüm tabloları, bir takım işte filtre değiştirme gibi çok değerli şeyleri var. Burada tabii öğretim destek dosyası dediğimiz araştırma ve öğretim amacıyla özellikle bu EKG'leri seçip depolayıp istediğimiz zaman hani retrospektif bir değerlendirme gibi çok değerli bize faydaları sağlayacağını ve birçok şeylere de fırsat vereceğini düşünüyoruz. Burada biraz daha görüntüyü biraz daha genişletecek olursak, gördüğünüz gibi kayıt üstünde bir yakınlaştırma, ölçümler için dijital bir cetvel oluşturabilme sistemin içerisinde ve filtre ve kayma hızlarını değiştirebilme gibi ve farklı dalga formu şekillendirebilme gibi bize imkanlar sunabiliyor. Yine özellikle ardışık çekimler, işte biliyorsunuz hani an be an sürekli hastanın anstabil, özellikle başta kardiyak hastalar olmak üzere ve diğer birçok durumda, toksikolojik durumlarda bu devamlı bir EKG kaydının olması bize kısa sürede çok değerli bilgiler veriyor. Aynı anda 3 tane çekimin yan yana üst üste görülerek değerlendirilmesi çok daha büyük bir avantaj sağlayabiliyor. Tabii bu doğru teknolojiyle hasta bakımında daha iyi bir sonuç elde etmemize, zamanın verimli kullanma, yanlış tanıdan kaçınma, özellikle yanlış tanılardan. Şimdi kafanızda bazı handikaplar belirdiğini tahmin edebiliyorum. Hasta bakım kalitesinde artma, personelin verimli kullanılması gibi çok hakikaten maliyetini ölçmeye ihtiyaç duyulan ciddi bir kazanım avantajlı bir yöntem. Tabii bu en son neticede bu tamam güzel teknoloji, dijital teknoloji, tamam EKG. Bununla ilgili gerçekten çok avantajlı yönleri olan, acil servis için çok önemli özelliklere haiz bir smart EKG, akıllı EKG teknolojisi. Saniyeler içerisinde bize otomatik EKG verisini hazırlayıp bizim değerlendirmemize sunan, yine ritim ve full disclosure teknolojisiyle kayıt üstünden seçilen bir 10 saniye bir süre içerisinde hastaya uyguladıktan hemen kısa bir süre içerisinde bize hastanın o andaki EKG kaydını verebilen ve daha da önemlisi kritik durumları, özellikle ST elevasyonu gibi, iskemi gibi, AV blok gibi, aritmi gibi ve bazı intervaller gösterme açısından bir Markut 12 SL dediğimiz ciddi bir kritik değer yazılım avantajı nedeniyle oldukça işimize yarayacak gibi görünüyor. Bir de sunumu bir örnekle bizim Aksaray'dan acil ve kardiyolojide değerlendirilmiş bir hastayla tamamlamak istiyorum. Son derece yararlı, güzel bir faydasını gördüğümüz 45 yaşında özellikle son bir saattir olan tipik göğüs ağrısı yakınmasıyla gelen bir erkek hasta bu. 6 ay önce inferior MI sebebiyle sağ koroner ve LAD'ye, sol ana koroner artere lezyon ortaya konmuş ve hastaya koroner arter bypass operasyonu önerilmiş. Hasta tabii kabul etmemiş. EKG'de prekordiyal derivasyonlarda ST elevasyonu ve T dalga sivirliği, T3 resiproku soru işareti. Bu hasta hiperakut MI ile ve benin erken repriorizasyon ön tanısıyla hasta acilde değerlendirilip daha sonra kardiyolojiyle hızlı bir şekilde yönlendirilen bir hastamız. Ve hastanın eski EKG kaydında prekordiyal T sivirliği ve ST elevasyonu olmaması, T3'te Q dalga ve ST elevasyonu mevcudiyetiyle hastada bir anevrizmatik ST elevasyonu ön tanısıyla hasta tabii ki bypass önerilerek operasyon sürecini tamamlamış. Beni dinlediğiniz için çok teşekkür ederim. Daha çok interaktif olarak soru cevap şeklinde sürece devam edebiliriz. Teşekkür ederim.
Evet, bu değerli konuşma için teşekkürler. Şimdi arkadaşlar EKG hepimizin yani en çok aşina olduğu ve bununla birlikte de sorun yaşadığımız bir konu. Ama uygulamalar ve bu yeni ufuk gerçekten bizim için farklı bir yere götürecek gibi görünüyor. Bu kongrelerde dinlediğiniz bazen bir paragraf bile size farklı yerlere götüreceğine emin olabilirsiniz. Sabahleyin Çin'den bağlantıda yine bununla ilgili çok önemli bir şey vardı. 5G ve acilin geleceği diye gerçekten bizi farklı şeyler bekliyor. Ben o zaman 2-3 tane slaytın resmini çektim ve gidince hemen onlarla uğraşacağım. Çünkü bu dönüşümü kim takip ederse o önde olacak gibi görünüyor. Bakın Roger Dickerson aramızda görüyorsun. Adam hiçbir şey anlamasa bile geliyor burada dersi dinliyor. Belki de anlıyordur da onu da bilmiyorum. Welcome Roger, okay. Şimdi yani hocam siz de biraz bu konularda mümkün olduğunca böyle aramızda görmekten mutlu olduğumuzu tekrar ifade edelim. Malpraktis davalarında da bahsetmiştik. En çok sıkıntı yaşadığımız konulardan biri ve hocam EKG kayboluyor. Nedense lazım olan şey kaybolur ya da hiç çekilmemiş oluyor. Veya biz hep delil olarak kullanıyoruz mesela EKG buydu gönderdik. İlk baştaki ilk analiz ile ilgili bunlar kolay. Ama bir de atlanan tanılar var. Bakın yıllarca biz mesela bazı sendromları göz ardı ettik. Diyelim ki Brugada sendromunu bazı arkadaşlarımız göz ardı etti. Ondan sonra Wellen sendromu. Biz doçentlikte falan sorardık. Wellen sendromu nedir diye. Wellen sendromu olan birçok hasta geri gönderildi zamanında. Ve acil tıp ve diğer doktorların en büyük kabusu şudur. Eve gönderdiğin hastanın sana ARES gelmesi. Bu unutulmaz bir şeydir. Ve bunu yaşamayan çok az doktor olacaktır. Ve bunların çoğu EKG'den kaynaklanıyor. Onu da söyleyelim. Şimdi EKG'nin dijitalleşmesi bize bir defa hasta değerlendirmede önemli bir avantaj oluşturuyor. Ama ikincisi de Sayın Dekanımızın bahsettiği gibi aslında yapay zekanın en iyi kullanabileceğimiz yer belki de EKG. Bu konuda çok ciddi çalışma yapmamız lazım. Hala biz EKG'ye değil, kendi tanımıza ve kardiyoloğun tanısına güveniyoruz. Bu klinikte çok değerlidir. Hiçbir zaman doktorun yerini alamaz cihaz. Ama burada bir grafi, bir elektriksel tespit var. İşte burada yapay zeka çok daha ön planda olabilir. Sizin görmediğinizi yapay zeka görebilir ve bunun doğruluk oranı, doktorların doğruluk oranını geçebilir. Bu dijitalleşmeyi hepimiz takip etmek zorundayız. Ama bunda da tek bir kural var. Makinelerden geri kalmamak için de elimizden geleni yapmamız lazım. Yani o bizden daha doğru. Onun söylediği şeyi mutlaka bizim de görebiliyor olmamız lazım. Bizim gelişime açık olmamız lazım. Bu konuda salondan tecrübelerini, katkılarını, sorularını bekliyoruz. Bunu kullanan arkadaşlar veya EKG ile ilgili ya kardiyolog arkadaşlar da vardı. Burada da oluyorlar. Ya işte o böyle değerlendirdi. Sonra işte gece anjiyo yaptık. Anjiyoda bütün damarlar tıkalı çıktı vesaire. Hepimizin başına geçen şeyler vardır. Evet, soru ve katkılarınızı bekliyoruz. Buyurun. Evet, Bişar, evet, adaşımız, hemşerimiz, buyur.
Hocam öncelikle çok teşekkür ederim değerli sunumunuz için. Ben sizin sunumunuzda özellikle şu noktayı çok değerli buluyorum. Maliyet etkinlik meselesi. Bu Başar hocamızın dediği yapay zeka entegrasyonunda ya da dijitalleşme sürecinde maliyet bir süre için yükseliyor maalesef. Bununla ilişkili olarak hani sizin öngörünüz var mı? Şimdi idari olarak bu süreci yöneten biri olarak bu konuyla ilgili olarak sizin bu işin olabilirliği ile ilgili bir öngörünüz var mı? Bu birincisi. Hocam ikincisi de Başar Hoca'nın bahsettiği bu yapay zeka dönüşümünde insan kaynaklı biaslar söz konusu oluyor maalesef. Bizim mesela şu anda bu konuyla ilgili bir ön çalışmamız var. Bununla ilişkili hazırlık yapıyoruz en azından. Sorun şu, hastaların EKG'sinin yanlış yorumlanması sisteme girildiği zaman o verileri kullanıp bir EKG yapay zeka programına çevirdiğinizde orada bir bias oluşturuyorsunuz. O yanlış tanı doğru olarak kabul ediliyor ve bunu devam etmek zorunda kalıyorsunuz. Bununla ilişkili olarak malpractice konusuna yansımasında sizin bir öneriniz olur mu? Yani böyle bir şey olduğunda malpractice arasında ne yapmak gerekir gibisinden.
Çok teşekkür ederim. İsim neydi?
Bişar.
Tamam. Bişar, tamam. Çok teşekkürler. Her iki soru için de güzel, değerli sorular için. Şimdi maliyetle ilgili bu tarafta şimdi artık idareci gibiyiz ama şimdi bir ara bizden birisi başhekim yardımcısı olmuştu acilden. Bir de bu ya işte nereden ne buluruz ne yaparız acilde aslında yıllardır biz maliyeti göz ardı ettik. Yani çünkü niye? Onları işte hesaba katmadık ama bu şeyden sonra acaba oradan mı, şuradan, suyundan, kemiğinden, oradan, buradan. Sonra ya bir gün şu EKG gündeme geldi. Ya her hastaya çekilen EKG'ler o kadar tonlarca. Hele şimdi kağıt maliyetini günümüzde düşünün yani. Maliyet deyince tersten bir şey yapayım. Yani bu kağıdın maliyeti şimdi o kadar şey ki o hale geldi ki yani. Yani şöyle ilk sunumda Paul Kivala'yla Brugada'nın şeyinde de benzer bir şey oldu. O teknolojinin dediğiniz gibi kullanımıyla ilgili yapay zeka, dijital, şu bu işte akıllı giysiler, şunlar, saatler, şunlar bunlar dendiğinde Brugada dedi ki ya bir taraftan maliyet, bir taraftan da işte yeni hasta profili oluşturmak, çoğalması. O da ayrı bir maliyet zaten. Yeni hasta demek yeni maliyet. Dolayısıyla o handikapları çözmek için biz de yani tüm paydaşlar tabiri caizse bu işte altyapı oluşturulması. Mesela atıyorum işte bunun otomasyon sistemleri özellikle. Otomasyon sistemleriyle birçok şey artık biliyorsunuz özellikle kağıt anlamında ortadan kalktı. Yani bazen de şöyle bir şey var. Yani şurada tabii biz acilciyiz. Hep onu diyorum. Biz bu tanı koymaya çalıştığımız hastaların büyük bir kısmı 50'den fazlası kim? Arreste giden kardiyak hasta yani. Ölümün ana şeylerinden bir tanesi. Dolayısıyla hani o işin şey kısmı yani maliyetin ihmal edileceği demeyeyim de insan hayatıyla teraziye koyduğumuz bir safha. Ama tabii ki bunun altyapısı iyi kurulursa otomasyon sistemleriyle bütün işte hastanın farklı hastanelerle bakıldığı zaman aslında tam tersine ciddi bir maliyet azalması oluşturacak bir şey. Yani buradaki teknolojinin satın alınmasıyla ilgili ilk etapta belki bir şey gibi görünebilir ama tam tersine genel düşündüğünüz zaman, bu işi biraz daha sistemik hale geldiği zaman tam tersine ciddi bir maliyet azalmasına sebep olacağını düşünüyorum, bir. İki, öteki soru da malpraktisle ilgili, o da çok değerli. Şimdi hastanın, özellikle bu şeyde bahsedecektim. İlk şeyde birçok hastada EKG'leri şöyle retrospektif dosyalardan bir tarasak, öyle çalışmalar da vardır mutlaka, aklıma gelmiyor şimdi. Çok büyük bir kısmı inefektif EKG değil mi? Yani parazitli, ne bileyim işte şu bu falan, iyi çekilmemiş. Bunlar büyük bir handikap dediğiniz gibi. Bu bu teknolojide çok rahat bir şekilde bu şeyi ne derler, sizin uygun görmediğiniz şartlarda yeniden güncelleme şeyi var. Hani sanırım öyle bir avantajı var ve optimale yakın bir şeyi elde ettikten sonra kayda alıyorsunuz. Dolayısıyla bu çok değerli bence. Hastayı yeniden sök, yeniden tak, bilmem ne gibi bir şeylerden, zaman kaybından tasarruf olarak o en optimal şeyi yakalayıncaya kadar güncelleme avantajı var bu teknolojide.
Çok teşekkürler. Tabii ki bu kaçınılmaz süreç. Bazı yanlışlar, eksikler, bunlar hep düzeltilecektir. Ama maliyet analizi de Mehmet Hocamızın ilettiği gibi maalesef şu anda idarecilerimizin ve günümüzün sorunu olarak hep kısa vadeli maliyet analizleri, bugünün maliyeti. Ama biz de hep bir bilim adamı olarak orta ve uzun vadeli maliyet analizleri yapıyoruz. Yani bugün bir hastayı, eğer hastalığını önlemezsen onun sana gelecek yıllardaki maliyetini hesaplamıyor yöneticiler. Tabii. Neyi hesaplıyor? Bugünkü maliyeti hesaplıyor. Buradan biraz daha orta ve uzun vadeli düşünmek gerektiğini de genel olarak ifade etmek istiyorum. Ona yani yönetici de o anda orayı idare etmeye çalışıyor değil mi Sayın Hocam? Ama maalesef ülke olarak biraz daha orta ve uzun vadeli maliyet analizlerini yapmak zorunda olduğumuzu da bilirim. Yoksa hep gelecekte yeni sıkıntılar yaşıyoruz. Evet, bu konuda Halil Hoca'nın da söyleyecekleri var herhalde. Buyurun Halil Hocam. Mikrofonla konuşalım, evet.
Hocam öncelikle bu farkındalık oluşturan güzel sunum için çok teşekkür ediyorum. Şimdi Başar Hocamın da özellikle değindiği üzere cihaz okuyor. Evet, yorumlama ile ilgili bu konuda değerlendirme sorunları var. Şimdi salondaki arkadaşlara sorsak, kardiyolojiden konsültasyona çağırdığınız hastalarla ilgili gelen kardiyoloji asistanlarının ortalama asistanlık süresi ne kadardır diye sorsak, eminim ki birçoğunda 2 yılın çok altında çıkıyor. Bizde mesela 2 aylık, 3 aylık, 4 aylık asistanların konsültasyona geldiğini görüyoruz. Bu yüzden dolayı da esasında bu cihazın verdiği değerlendirmeler, bize verdiği şeyler çok daha önem kazanıyor. Bir de acil tıpçılar olarak bizim konsültasyon için çağırdığımız bizim kendi asistanlarımızın süresi en erken çağıran en az 2 yıllık, 3 yıllık asistan konsültasyon için talepte bulunuyor. Bu yüzden dolayı da kardiyolojiden konsültasyon amacıyla gelen asistanların süresiyle ilgili bir kısıtlama olması lazım. 2 yıldan düşük süresi olan bir asistanın konsültasyona gelmemesi gibi mesela bir şey olabilir. Bu hastaneler bazında olabilir veya genel bir uygulama şeklinde olabilir. Çünkü bir insanın eve gitmesi veya kalması ya da işte arrest olarak geri gelme ihtimalini de dikkate aldığımızda bu konunun özellikle kardiyolojiyle de içli dışlı olan bir cami olarak belirgin şekilde vurgulanması gerektiğini düşünüyorum hocam.
Teşekkür ederiz Halil Hocam, katkılarınız için değerli.
Evet, çok teşekkürler. Gerçekten bunda da yani hepimiz birebir bu sorunları yaşıyoruz. O yüzden yani şu andaki şartlar değilse de Halil Hocam mutlaka yani teknolojinin nasıl ilerlediğini hepimiz görüyoruz. Baş döndürücü şeyler oluyor şu anda. İleride 5-10 yıl içinde insan hatasıyla bu yapay zeka, onun için söyledim. EKG yorum oranları hatası karşılaştığında yani bunun çok daha kullanılabilir hale geleceğini göreceğiz. Ve ileride bunlar delil olacaktır. Hasta takibinde, davalarda, Onun için de elimizde böyle imkanların olması önemli. Bir de tabii ki bu ölçümleri büyüterek yapmak konusu çok önemliydi. Ben onu Mehmet hocamız vurguladı. Mesela şimdi EKG'yi alıyorsun, küçük bir cihaz, üstünü oynayamıyorsun değil mi? Yani biraz çoğu zaman EKG'ye bazen gözlükle bakmak zorunda kalan arkadaşlarımız da olmaya başladı tabii süreç içinde. Şimdi bu dijital cihazların bir özelliği, onu verdiğimiz sene boyunca verdiğimiz kurslarda çok iyi analiz etmiştik. Ya büyütüyorsun, birden oranları hesaplama imkanın artıyor. Mesela işte V1'deki R, V6'daki T oranı, bu bahsettiğimiz Doktor Smith, aslında Emanmat'ta çok duyuldu da Doktor Smith onun hocası, bu işlere kafa yoran ve matematiği, EKG'yi tıbba sokan bir kişi aynı zamanda. Aslında onların bizden fazla yaptığı bir şey yok. Benim de buradan çıkan sonuç, şunları rica ediyorum. Arkadaşlar siz de şu oranlara çok dikkat edin. Yeni şeyleri biz bulalım. Yani onlar buluyor, biz de bulabiliriz. Hep matematik oran yapın. Mesela lenfosit, nötrofil lenfosit oranı en çok Türkiye'de çalışılmış. En basit çalışma olduğu için en çok bütün şeyleri biz yapmışız. Böyle oranlarda iyiyiz. Çekiliş sözümüz var. Alalım çekilişi.
Şimdi,
burada bitireceğiz herhalde. Diğer hocalarımız geldi ama bir saniye bekleyin.
Sayın Başkanım, bu ölçümlerle ilgili bir bildirilerde bir arkadaşımızın güzel bir çalışmasını da görmüştüm şeyde. Belki dikkatinizi çekenler vardır. Arkadaşımızın ismini hatırlayamadım ama bu EKG'de hiperpotosemiydi galiba. Onunla ilgili bir çalışma vardı.
Bildiriler arasında mı?
Bildiriler arasında.
Evet, orada Becet Hocam bir söz istiyor. Hemen Becet Hoca'yla devam edelim. Sonra çekiliş yapacağım. Evet Becet
Hocam çok teşekkür ediyorum. Ben biraz beylik bir söz olacak ama EKG acilcinin işidir. Şimdi kardiyolojiye yatan bir hasta tanısı konmuş, adı konulmuş, tedavisi başlanmış, ne olduğu belli olan bir şeydir. Dolayısıyla buna sadece kontrol EKG'leri çekilir. Ama acile sıfırdan gelen bir hasta, zaten işte bariz olan ST elevasyonları falan filan onları bir geçiyorum ama özellikle biraz önce Mehmet abi de bahsetti. Mesela işte Brugada sendromu, Wellen sendromu, Wolff-Parkinson-White, bu tanıları kim koyacak? Bunları acilci koyacak. EKG'yi en iyi bilmesi gereken biziz. Bu bizim işimiz. Kardiyolojinin işidir, değildir demiyorum. Bunu kastetmiyorum. Yanlış anlaşılmasın. Onları dışlamıyorum. Ama EKG'nin sahibi, EKG'yi en iyi yorumlayan, en hızlı okuyan, tanıyı koyan acil tıp uzmanları olması gerekiyor. Bu şarttır. Siz orada şeyleri eğer çok nadir gördüğümüz mortal seyreden şeyleri eğer biz görmezsek, atlarsak bu hasta biraz önce de bahsedildi, ARS bir şekilde gelir. Yani EKG kardiyolojinin işidir diye söylemek, hele bir onu çağırayım gelsin değerlendirsin ne var o görsün bize bir şey söylesin demek bizim biraz acizliğimiz oluyor. Bunu aşmamız gerekiyor. Teşekkür ederim.
Çok teşekkürler. Tabii Becet Hoca'nın ne demek istediğini anladınız. Yani acilci EKG'yi en az bir kardiyolog kadar veya diğer branşlar kadar bilmek zorundadır demek cümleyi böyle bağlayalım. Bizim işimiz tabii ki birçok işimiz var ama EKG'yi bir acil uzmanı bir kardiyoloji uzmanından daha az bilmemek zorunda. Yani EKG hepimizin ortak işi. Onlar da bilecek, biz de bileceğiz arkadaşlar. Ben çekiliş yapacağım. Ve bu konuda biraz daha detaylı bilgi için stand var herhalde. Orada görebilirsiniz. Mutlaka oraya uğrayın. Bu büyütme, küçültme hareketlerini falan da orada görme şansınız belki olabilir. Bunların dışında da çekilişten sonra da şimdi alıyorum bir tane. Umut Gül açtı. Umut burada mısın? Bak ben böyle yakalarım çıkanı işte. Aslında şanssızlık. 2 dakika önce çıkmıştır Umut. Bir daha çekmek şansımız var. Şöyle karıştırarak. Fethi Atılgan Ahmet. Fethi burada mısın? Kongre kaydın tamam bizde. Seneye buraya veririz. Evet arkadaşlar. Şimdi arkadaşlar Brugada, Paul Kivela, Roger Dickerson burada özellikle Brugada son defa bize önemli bir konuda bilgilerini aktaracak. Ara vermeyelim ya da bir çay alıp buraya gelin 5 dakika içinde. 5 dakika içinde ya da ara vermeyelim. Burada bu resmi burada verelim, yani beraberce Buruk adayla burada diğer çok değerli katılımcılarla dersi dinleyelim arkadaşlar. Aramız yok ya da en fazla bir çay almak isteyen çay alıp gelsin. Buradayız.
confusion. Now, in this paper, they made the suggestion that we should be taking this binary approach, and instead of going with 4 groups that I mentioned before, going through the angina pectoris, unstable angina, NSTEMI, and STEMI, of simply dividing it up into 2 broad groups. And what they suggest is ST elevation myocardial infarction, and then everything else. And the reason for that comes down to how we acutely manage these cases in the emergency department. It is a binary division that assists us with regards to which patients need to have imminent interventions and which ones don't. And so they've added another multi-letter acronym, which is the non-ST segment elevation acute coronary syndrome. Now, I'll try to say that fast. I suppose it's the NSTACS, but it does simplify our decision-making, but also simplifies the management that we are able to institute. Now, when we're looking at the problems that we discover in the coronary systems and the absence or partial absence of blood supply to the myocardium, we need to ensure that we have an understanding about what is actually going on. We understand that when we're looking at the damage that can occur, it can be a temporary scenario, something like a vasospasm, like we see in the Prince-Metals anginas. It could be something that has resulted from elsewhere, so a clot that has moved or a thrombus that has moved from elsewhere, or it could actually be a thrombus that has propagated within the coronary vasculature. Now, what's important is that if we have a look at whether we're talking about STEMIs or NSTEMIs, it's very difficult to make a distinction as to what is actually the cause of what the patient is presenting with. We're seeing changes on ECG, the patient is presenting with chest pain. And the question that we need to ask ourselves is, are any of these important in our acute management of the patients? And the answer is probably no. It's not that important in the first 5 or 10 minutes of a patient presenting to our emergency departments to make the distinction between these pathogeneses. The important thing is to recognize that a problem is there and to institute the appropriate therapy once we do. So how do we diagnose myocardial infarctions? And the hallmark has always been applying an ECG to a patient. So we record an electrocardiogram and we make interpretations. Now, when I was doing my training initially as a medical student and then later on as an EM resident, there was a cardiologist at the hospital that we were at who'd been working at the facility for near on 30 years. He'd then gone on to do a PhD in Egyptology. And we thought it strange that a cardiologist would want to do a PhD in Egyptology. And then he explained to us that he was used to looking at hieroglyphics when he looked at ECGs and interpreting them. So it seemed a natural step. But we do need to look at an ECG and hopefully be able to make and recognize the signs of an acute myocardial infarction. The difficulty, though, is that there are many things that mask or that mimic the changes that we see on ECG. And we've got a very eminent member in the community sitting in the audience today who explained exactly that yesterday, where we can see that a lot of the channelopathies presenting with what may look like a myocardial infarction. And so we can't pin everything on our diagnostic ability on a simple piece of paper or a simple image. We need to take everything into account. Now, I must admit, when I first learned that I was going to be speaking in the same session as Prof. Brigada, I started having chest pain myself. But this is my tribute to him.
Oh, doctor, I'm in trouble. For every time a certain man is standing next to me, A flash comes to my face and my pulse begins to race. It goes boom, boody, boom, boody, boom, boody, boom, boody, boom, boody, boom, boody, boom, boom, boom, boom, boody, boom, boody, boom, boody, boom.
Goodness gracious me.
So I suppose it is fear. And this is what we do in emergency medicine, is that we perform under pressure. So let's go back to our diagnostic ability. We've said that we do need to do an ECG because a lot of what we decide is based on the changes on the ECG, but we do have some ancillary tests that are able to assist us. And that is usually done with a troponin. So it's that combination of ECG changes, a troponin test, and then looking at the patient's presenting history. And with that coming up with a symptom complex that is going to indicate us to a diagnosis or a provisional diagnosis, and then take us down a decision pathway that will lead us to the appropriate management. So that's great. We've done our ECG, we've done our ancillary tests, we've examined the patient, we've taken a good history. What now? So we've got some protocols, and there are some that I'm going to be going through today, which are in the same ilk of this binary approach to the acute coronary syndromes. But we start looking at protocols, and it reminded me of something I was taught when I was quite a young man, and as I've become older, it has become a bit of a truer explanation. And that is that rules are for fools, but they guide wise men. And as we become more experienced, we see more patients, we see more of the variations that patients present with, we can adapt these protocols and clinical guidelines based on our own experience, but also looking at our local infrastructure and needs. Now, in this paper that was published earlier this year, using this binary system and separating the acute coronary syndromes into the ST elevation myocardial infarction or the non-ST elevation acute coronary syndromes, it did simplify things. So when we're looking at STEMIs, that's really simple. If you've got PCI available to you, great, proceed with the PCI, it is the best outcomes. If you don't have PCI available and they suggest a time frame of 2 hours, that the optimal therapy would be to proceed with some kind of fibrinolytic or thrombolytic. And if that is successful, great. If it is not, you will still need to proceed on with PCI, and that should be within 24 hours. So the question then becomes, what about those that are falling into the other group? What about those that are falling in, that have not presented with an ST elevation myocardial infarction? And what we need to understand here is that it is very dependent on what is available to you. So yes, we need to consider that patients may still need a PCI, but it is more from a diagnostic perspective than an interventive perspective. And now we can start separating these patients into the two broad groups. So looking at the NSTEMIs, and that way we would want to proceed with a PCI as a diagnostic ability at a later stage, and then looking at unstable anginas and looking to see if there are any signs of that would place the patients at high risk. So looking at things like heart failure or ECG changes, if the patient has got ongoing chest pain despite our interventions, or if there is any kind of hemodynamic instability. And we do need to ensure that we can institute our maximal medical therapy and hopefully get some better control of risk factors. Now, it's something that we often find difficulty is that we have patients presenting with chest pain, and you say to them, when did you stop smoking? And they said, when I started having the chest pain. And you said, are you going to smoke again? No, doctor. But they will certainly be returning to it as soon as you've sorted out their chest pain. If we are going to proceed on to the coronary angiography, and you'll notice that it is based on a time frame according to the diagnosis. So From a STEMI perspective, it should be immediate. From an NSTEMI, you hopefully within 24 hours. And then the unstable anginas we could do as a more elective procedure. If you are able to demonstrate there's any kind of obstruction, we then need to look at how we are going to make that intervention. And that may be from a medical basis, it may be on an interventional radiological basis or cardiological basis. And lastly, it may be simply with regards to the administration of baseline medications. I think what we often tend to forget is how important the antithrombotic therapies are. And something as simple as aspirin or Plavix or clopidogrel makes a great impact with these patients' prognoses, particularly when it comes to reinfarction at a later stage. When we look at medical therapies, and this is where we can really make an impact from an emergency medicine perspective, particularly in that group that are not for either PCI or thrombolytics. Because the earlier we are able to commence these therapies, the better outcomes we see in these patients. And there are many drugs available to us from the statins through to beta blockers to ACE inhibitors, and hopefully we'll be able to improve the patient's outcome and limit the morbidity and mortality related to these conditions. I think we do need to accept, though, that there are going to be a small subgroup of patients that we are not going to be able to make any interventions on, and they are probably not going to have a good outcome. And that is always a problem. And it's those patients where we are either not going to be able to introduce that antithrombotic therapy due to contraindications, or where we will have difficulty with some of the medical therapies because of the concomitant instabilities. And those are the cases that keep us up at night and give us the nightmares. You do need to have a look at your own facility. You need to look at your own capabilities within your facility, both from a skill perspective and from an infrastructure perspective, and where that fits into the greater medical system that you are working in. You need to have clear referral pathways and referral guidelines so that we are able to stream patients to the most appropriate areas in the medical system as fast as possible and not inappropriately. So we do need to have access to cardiologists. We do need to have access to interventional cardiologists so that we can improve the outcomes for our patients. And if it's not at your facility, you need to work on these referral pathways in the clear light of day and not when there is an emergency, so that we can ensure that these patients are clear. That may mean moving a patient from one site to another, and we again need to ensure that we have appropriate levels of care and appropriate means of transport for these patients to get them to the referral facilities speedily and ensure that they have ongoing care that is appropriate for their needs at the time. If we have a look at what we've been speaking through, it does apply to a very small subgroup of patients who present to emergency departments with chest pain. But it is critical that we are able to recognize these patients and make the appropriate interventions should the need arise. We also need to understand that patients may present to us in various times following the onset of their chest pain and the onset of the pathology. And that can also interfere with how we would manage a patient. So it makes absolutely no sense to make some of the interventions that we've spoken through this morning if a patient has presented outside of an appropriate time frame, and if they in fact have a missed myocardial infarction. When it comes to thrombolysis, we spoke a little bit about this yesterday, but there are many checklists with regards to whether patients should be thrombolized or not. I'm not going to go through that now. I do need to emphasize the importance of consent, particularly in any of these interventional procedures. The patient needs to be informed as to what their requirements are, what the potential complications are, and in this situation, the risk of death, so that they can make an appropriate decision. because these drugs are poisons, and given inappropriately, they can have a very deleterious effect on the patient. And so it does become a bit of a balancing act, trying to balance the patient's needs on the one hand, what they are capable of having from their concomitant pathologies perspective, and then also looking at what we have available to us within our infrastructure, whether it is from a medication perspective or access to interventional cardiology. And I guess this is probably the most important comment that any emergency physician can learn, and it's something that we always teach our residents, is that when they get a difficult question in an exam, is start off by answering, "It depends." Because what it does is that it gives you a little bit of time to think, to assess what we've got available, what the patient's clinical condition is, and the nature of the STEMI, and make an appropriate decision based on that. Now, the reason I've got a picture of one of the dragons from the Game of Thrones is that we have had situations where we're speaking to our cardiologists and they are quite difficult. And this is where it becomes very important to ensure that you have good relationships with the other departments, but also that you have clear referral pathways and guidelines set up prior to an emergent event. Because if there's a clear understanding from both sides, from cardiology and from the emergency department, as to how we can work together to provide the most appropriate care for patients. And really, if you do that, you can turn this type of a dragon into one of these. Since I've been young, I always saw that myocardial infarctions were one of the most important things to manage. It's something that hit my family when I was a very young person. And certainly when I've been looking at how we can improve cardiac care, I've always taken a very personal approach. And I think what we do need to understand is that the appropriate care for these patients not only saves lives, but it can ensure that young boys don't go without their parents. I would encourage you to have a look at this article. I think it is a very clear approach. I hope I've given some kind of summary of the detail that is included in it, and I would encourage you to have a look at it if you are so inclined. And then finally, I would just like to express my appreciation to Prof. Kanda, not only for the kind invitation to speak at this conference on a continued basis, but also for the efforts that he has made with regards to emergency medicine, not only within Turkey, but also looking at emergency medicine within the region and across the world. And I think it's only right that he has now been crowned and is the incoming president. With that, I'd like to express my appreciation to everyone, and thank you very much.
Thank you so much, Dr. Dickerson, for a wonderful and insightful speech. Our next speech today will be from Dr. Brigada, a leading expert in cardiac arrhythmia and sports cardiology. Dr. Brigada has published more than 350 scientific papers and known for his excellence in the field, and of course, Brugada syndrome. Interestingly, beyond working at a hospital, Dr. Brigada travels 3 to 4 times to Africa, where he treats children with arrhythmias. That being said, please welcome Dr. Brigada as he talks about his specialty.
Thank you, Ariel, thank you, Paul, thank you, Dr. Kander, for very nice invitation again. I will try in the next minutes to talk a little bit about how do we manage complex situations and what the guidelines say and how we can treat our patients in the best possible way. We were talking yesterday that sudden cardiac death occurs in different settings of structural heart disease, ischemic, dilated, hypertrophic, and arrhythmogenic. But this is not what we are going to talk today. We were referring yesterday to the same slide saying that in about 20% of the patients suffering from complex cardiac arrhythmias and maybe sudden death, there is no structural heart disease diagnosed, and the patient has what we call a normal heart. And in this population is where the term channelopathies has been used to describe a number of conditions, all of them related to mutations and changes in the structure of the ionic channels in the heart that produce some effects, some of them on the electrocardiogram, and we can make the diagnosis out of the electrocardiogram, but also on the electrical gradient between different parts of the heart that finally produce ventricular arrhythmias, ventricular fibrillation, and sudden death. And we were yesterday explaining that at least 5 conditions have been described over the last 4 decades, which is the long QT syndrome, the short QT syndrome, the Brugada syndrome, the catecholaminergic polymorphic ventricular tachycardia, and the malignant early repolarization. The common issue in all of these arrhythmias, in all of these conditions, is that finally ventricular fibrillation can occur in different ways for different mechanisms, but at the end the heart fibrillates and the patient dies if we don't take an action over this arrhythmia. What makes patients with channelopathies different from other patients at risk for sudden death? Basically because they are often young and active, so that means that they will have a very long lifespan. They are patients that are growing. They are patients that might have sinus tachycardia, will be sportive, will be doing a lot of physical activity. They usually have a structurally normal heart, so there is no evident risk of dying from other causes. So the only cause that might kill them is the channelopathy by itself. Very often they might not be completely aware or might not completely accept their own condition and risk. Basically, when we are talking about adolescents and young patients, it's very difficult for them to understand that they might have a condition which produces no symptoms, but suddenly can kill them, and that they have to take some measures to avoid this to happen. However, there is no symptoms preventing them to have it. But also we have to say that the treating physicians might not have clear risk stratifiers. We are working and working on trying to identify which patient with any of these conditions is the one that will present sudden death. And we are still far from having a very good risk stratification process. We advance, we know more or less, but still we are identifying far more patients at risk than the ones finally having the risk. And sometimes we are missing to identify the patient that finally will die. So still a lot to do in this issue, and probably one of the clear themes to be studied and investigated over the next years. This is a newborn. He has a spontaneous torsada de pointe, more than 100 per day. But it's okay, it's a newborn, so it's difficult that explains anything. And if you look at the QT interval, it's a very prolonged QT interval, very strange wave with a 2-to-1 block. You have here a P wave that is blocked. The QT interval is so prolonged that the patient has a 2-to-1 block. This is a very severe condition, and when you look at this, arrhythmias, they are really scary. More than 100 per day. Okay, so this is a newborn with a long QT, 2-to-1 block, a lot of ventricular arrhythmias. Beta blocker was initiated and no effect at all was obtained. So it could be done genetic testing, and a mutation in the sodium channel was diagnosed. So if we go into the guidelines, you see that patients with long QT, if the patient has had a prior cardiac arrest, an ICD is recommended. This patient has had a lot of non-sustained, very scary arrhythmias, but no real cardiac arrest. If there is a recurrent syncope while on beta blocker, well, then an ICD could be useful. This is not exactly the case neither. And if the patient is asymptomatic and not treated with beta blockers, then the ICD is not indicated. But in this case, it does not fit in any of these cases, because the patient having a lot of arrhythmias, not having cardiac arrest, but is not treated properly with beta blockers. So that means that maybe we have to think about other things, and in this case, about genotype-specific therapy. We have said that this is a long QT because of sodium channel mutation, so this is what we call the long QT3 syndrome. And this is one example on how genetic can help, not only in the diagnosis, but also in therapy, because in this patient, we gave flecainide and mexiletine and normalized everything, including the QT interval, and the arrhythmias disappear. So how important it is in these cases to have the genetic analysis. Look at this example. This is a patient with, again, a very prolonged QT interval that has non-sustained torsada de puantes that are coming and coming, and beta blocker again had no effect. In that case, we did the genetic analysis and no mutation in the sodium channel was documented. So we could not use, as in the previous case, the mexiletine or the beta blocker. So we are again in the same situation here. So beta blocker is not useful, but the patient is not having cardiac arrest. Shall we implant an ICD? No, because he's having non-sustained arrhythmias. Probably we have to think about other therapies, and left cardiac sympathetic denervation might be one option in this case. So we can do, this was again a newborn, we can do the left stelectomy, and you see that the situation normalized completely on the arrhythmias. So again, it's very easy sometimes, because you have ventricular arrhythmias, to immediately go and implant an ICD. You can imagine the difficulties of implanting an ICD in such a patient. However, we have alternatives that we should, of course, explore, in this case, the left stelectomy as one of the major surgical decisions that might help the patient. Let's look at this. This is a patient, which is this one here, a 30-year-old female that belongs to this family where 1, 2, 3, 4, 5 members have died suddenly due to long QT syndrome, and you will see immediately the ECG. She came to our attention, that's 1988, okay? And this was his family history. That's her ECG. You see a QT interval of 640 milliseconds, corrected by the frequency at 584, extremely prolonged QT interval, but she's completely asymptomatic. 5 years later, 1993, she comes back to us, she comes back to us, please check here. Her sister, her mother, had prolonged QT interval but were alive in 1988. In 1993, her sister and her mother also suffered sudden cardiac death. So she is the only survivor in this family having a prolonged QT interval. And she is asymptomatic, completely asymptomatic. If we look at the guidelines, okay, there is an asymptomatic not treated with beta blockers, the ICD is not indicated. Of course, she was already on beta blockers since 1988, but still asymptomatic. But here, I want to ask you, what about the family history? Because you have a family where 8 members, including your sister and your mother in the last 3 years, have died suddenly. How can not implant this patient? This is a patient that, even being asymptomatic, because of the family history, the risk of dying, of course, even only morally speaking, you have to protect her. But the guidelines do not talk about that. The guidelines do not take into account this case. For the guidelines, this is an asymptomatic lady with a prolonged QT interval treated with beta blocker and no syncope, so for the guidelines, she's doing fine. So of course we did implant this lady, because it was evident that the whole family died because of the prolonged QT interval. Okay, she's now 64-year-old. She remains completely asymptomatic. He has undergone 4 ICD replacement, continues to have a long QT in the ECG, and he never had off-bring because of fear to transmit them the disease. So she has never had a single arrhythmia. But still, I believe that 30 years ago I did the right thing, that was to protect her because of the family history that was so heavy and because of her ECG that was so malignant in the aspect of having a QT interval of 640. But as you see, she's the survivor in the family. So sometimes guidelines are difficult to interpret. Sometimes we have also to take into account the personal circumstances, the family history, and decide accordingly. Okay, this is a patient with Brugada syndrome, the classical ECG, similar to the one that Roger has shown before, and we know that these patients might, in some circumstances, have ventricular fibrillation and sudden death. This ECG here belongs to a taxi driver from Uruguay. He was driving her car and had a syncope and had a car accident. He was admitted in the Spanish hospital in Montevideo, and while he was in the emergency department and the ECG was recorded, he presented ventricular fibrillation spontaneously at that moment. This is the first case ever published of a spontaneous ventricular fibrillation in a patient with Brugada syndrome. That was 35 years ago. Sometimes we have ECG which are very clear. This is a 9-year-old girl presenting with syncope, and she had a family history of Brugada syndrome. So there is no doubt that this is a very abnormal ECG in a very young girl with a family history and cardiac syncope, and there is no much doubt that she has to be protected because the risk of dying suddenly is extremely high. But sometimes we have cases like that. This is a 13-year-old boy look at the ECG, he was admitted in the hospital because of fever in the emergency room, had no family history, no previous symptoms, nothing, while in the waiting area he had cardiac arrest. So this is one of the forms of presentation of Brugada syndrome. The fever is one of the triggers for abnormal ECG and for ventricular arrhythmias and sudden death. And we have to be extremely vigilant in the patients with Brugada syndrome to treat very aggressively fever to avoid the patient to have prolonged fever, because this might lead to the occurrence of sudden death, like in this case. We know that the patients with Brugada syndrome have what we call electrical storms. So they might be completely asymptomatic for years, and then suddenly they might have 8, 10, 20 episodes of ventricular fibrillation in 1, 2, 3 days. And then it stops again, and they remain asymptomatic for a very prolonged period of time. And we are still trying to understand why this behavior in the patient with Brugada syndrome. So if you look what the guideline says for Brugada syndrome, it says that, of course, if you have had a prior cardiac arrest, you should be implanted. If you have a spontaneous type 1 and a history of syncope judged to be caused by arrhythmias, then an ICD can be useful. If you have a type 1 ECG, asymptomatic, but you are inducible on the ventricular fibrillation in the electrophysiological study, an ICD may be considered. And if you are asymptomatic and you have a drug-induced type 1 ECG, the ICD is not indicated. That's what the guidelines said. Let me show you an example. This is a 49-year-old male. This is his basal ECG, which has an incomplete right bundle branch block, but no real type 1 ECG. But he had a family history of Brugada syndrome. His brother had sudden death. So it was decided that a pharmacological test would be performed. So the Ashmelin test in 2014 was performed, and you see here the result of the Ashmelin test compared to the basal ECG, and you see a very clear type 1 ECG, so a very positive Ashmelin pharmacological test for Brugada syndrome. Remember, he's asymptomatic, but his brother had sudden death. So at that time, we recommend to do an EP study, which is not the case everywhere in the world, because you know that there are some discussions about the use of the EP study. In many sides of the world, many centers, the patient would just be left without nothing because the EP study is not considered. We do EP study systematically, and you see here that during EP study, ventricular fibrillation was induced. So in our protocol, if ventricular fibrillation is induced during the EP study, we recommend to implant an ICD, and this is what it was done. A subcutaneous ICD was implanted. So remember that this is an asymptomatic patient. 2 years later, this patient presented with an electrical storm. He had 7 spontaneous BF episodes treated appropriately by the ICD. So when we have this situation of an electrical storm, we can use sometimes quinidine, which reduces dramatically the number of events during follow-up, although it does not bring them to zero. Or in the very last years, we and others have developed the possibility of having what we call an epicardial ablation of the electrical substrate in the right ventricular outflow tract, which normalizes in general the ECG and the inducibility. These are the types you see here, the ST elevation. This is the area of the epicardium of the right ventricle, which is this, with these abnormal signals that we can record, and this is the ECG, the Ashmelin test before the ablation. this is the adrenaline test after the ablation with no modification at all in the ECG. And this is the inducibility before the ablation of ventricular fibrillation, and after ablation, no inducibility can be obtained. So that means that we are advancing and that we are generating new information and very interesting issues, like the fact that we can modify the phenotype of a disease which is genetically determined by using a mechanical therapy, which is the ablation. And this is something that probably is unique at that moment in medicine, and we will have to think about how this is working, what is the pathophysiology of all that, and how this is used in the future to treat our patients. This is a 10-year-old lady, diagnosis of and therapy for epilepsy since age 8. She had a good initial clinical control, but at age 9, new symptoms start to develop in form of syncopes. And the Holter showed this. So sometimes some extrasystoles becoming more frequent, with bidirectional extrasystoles becoming more and more aggressive, and finally this extremely fast, polymorphic, very abnormal tachycardia, not producing sudden death, producing syncope in some of them, but spontaneously recovering during the day. So this is the case of a familial polymorphic ventricular tachycardia that we were also explaining yesterday, where the ryanodine channel is affected, producing an accumulation of calcium inside the cell during situations of mental or physical stress, and producing an intoxication of the cell by intracellular calcium accumulation, and producing this type of arrhythmias. So the beta blocker is the therapy of choice in the majority of patients. By using beta blocker we can treat, but sometimes, like in this case, using beta blocker is not enough to treat the patient. And sometimes you have to use flecainide, adding to the beta blocker to normalize or minimize the ventricular arrhythmias during follow-up. Again, one would very easily imagine that if you have this sort of arrhythmias that I have shown here, you will immediately want to implant an ICD, because you have the fear that the patient might die suddenly. Remember that catecholaminergic VT, the arrhythmias occurs because of an increase in the adrenergic tone. If you implant an ICD and you have an inappropriate therapy, or therapies while the patient has not completely lost consciousness, you will increase the adrenergic tone of this person, and you might produce more and more arrhythmias. So the ICD might be very pro-arrhythmogenic and no antiarrhythmic. So that's why you have to ensure medical optimal treatment with beta blocker, flecainide, sometimes verapamil, and just be careful and not rush towards an ICD. And again, left cardiac sympathectomy can be a very good solution before going for an ICD. And because this is one example, but there are many in the literature where an electrical storm is produced by the defibrillator itself, and the patient finally dies because the defibrillator finishes his therapy protocol, but the patient is still in ventricular fibrillation because the shocks produce more shocks, more arrhythmia, and more shocks. So be very careful implanting defibrillators in this type of patients, and consider all possibilities before, and the left cardiac hysterectomy is a very good solution in many of these patients also. So treatment is beta blocker. If symptoms of arrhythmia during stress persist, consider adding flecainide. If symptoms persist, consider left stenectomy, and very, very rarely ICD should be considered because it can be clearly pro-arrhythmic. So in conclusion, I want to say that channelopathies represent a very specific family of diseases, producing sudden cardiac death in patients with a structurally normal heart. However, and that's what I tried to explain in this presentation, a very, very individualized study and management is mandatory. It's very difficult to have rules and protocols that apply to every single situation, because every single situation is different. It's different in terms of the social aspects, the family aspects, the symptomatic aspects, pathophysiological aspects, genetic aspects, and all this has to be taken into consideration for the management of every single patient, because of course every patient is a unique patient that requires probably a very unique and personalized therapy. Thank you.
Thank you, Dr. Brigada. Are there any questions from the audience for Dr. Dickerson or Dr. Brigada? Guess we're going to need some mics up here, please.
Thank you very much, Dr. Brigada, for this very nice presentation. And you present very nice and interesting cases. My question is about that. Is it possible for prediction to recognize the canalopathy? Is it possible to get ECG for all newborn who have any patient with cardiac sudden arrest in family? Do you suggest to get ECG for all the newborn who have, any person in their family with cardiac arrest?
Yeah, we had this discussion yesterday already, about the use of ECGs in the whole population, and how we can suggest our authorities that everybody should have an ECG performed sometimes in life, because the ECG will identify the patients at risk for sudden death. That's clear. It's true that the incidence of abnormal ECGs, and we were discussing that also, it's about, of true abnormal ECGs, about 0.6% if you do it in the general population. But to arrive to this 0.6%, you will have something like between 3 and 5% of the patients with an abnormal but not clearly abnormal ECG that would require that you do other things like echocardiogram, stress test, whatever. So yes, of course we have to do ECGs to everybody, and that will be very good for identifying the Wolf Parkinson White, the QT, the Brugada, the short QT, whatever. Sure.
Thank you.
Great. We have time for about 2 or 3 more questions.
Okay, thank you for your presentation. I would like to ask a question about long QT and Brugada syndromes, because your presentation makes me feel like the guidelines are underestimating the long QT syndrome and Brugada syndrome. It makes me feel like that. So what would be the harm to use ICD for prophylaxis, just for long QT syndrome or Brugada syndrome? Because they're gonna end up like that unless they are not treated, right?
The harm of
what would be the harm for using ICDs prophylaxis?
Well, the harm for the economy of the country, If you're using ICDs to everybody, this is really very expensive. I think you have to use the ICDs in the patients that require an ICD. When we are talking about sudden death, it's very easy to say, sudden death risk, ICD. I don't want to have any risk for the patient, so I would implant every single patient that I think might have a risk. Sometimes this is happening in some countries, that there are an over-indication of ICDs in patients that I don't think they require. There is also an over-diagnosis in some patients of Brugada syndrome. There are many patients that have an incomplete right bundle branch block and early repolarization, and then somebody says it's a Brugada syndrome, they have a vasovagal syncope, and then they implant an ICD. And this is something very usual, I would say. And I think this is completely wrong. Okay, so you have to be very careful in making the diagnosis of Brugada, because you really need to have a type 1 ECG and you have to demonstrate it, and when you demonstrate, then you have to do the risk stratification and decide which patient might require an ICD. Of course, in everybody living with sudden death, we all have some medals, in our life, that somebody that we thought it was no enough risk to implant, then they died suddenly. And then, of course, you always have the feeling that you might have done the wrong thing, okay? It's true that I receive every single week, several patients around the world, information on several patients saying, they have diagnosed me a Brugada syndrome, can you please confirm it, etc., etc. And then I can tell you 95% of the patients I receive, they are not Brugada. And I say, no, you don't have a Brugada, you have an incomplete right bundle branch block, I don't think you need this and that and that. Every time I write down this, on the email or whatever, I have the feeling that one of these guys is going to die because of myocardial infarction. Because some of them will have a myocardial infarction one day, and they might die suddenly, and then they might come to me and say, hey, you told me, or you told my husband that he's not going to die suddenly because he has not Brugada. Yeah, of course, but he might have died of myocardial infarction. So this is something that we as physicians, of course, we have to understand how to manage all these things, especially, on the era of emails and social media, etc., etc. We have to be very careful because, of course, we are providing information that might be interpreted in the wrong way, okay? So, but again, I still think that we have to see every patient, we have to make the right diagnosis in every patient, and we have to make the right risk stratification. It's too easy to say, we are talking about sudden death, we implant an ICD. Because of course you will have the problems of the ICDs, which are many. Especially for cables, etc., young people, cables that broke, infections, endocarditis, etc., etc., etc., and we have to be very careful with that.
Thank you for your presentation. In your presentation, I saw a patient who has type 1 ECG and got benefit from the ablation therapy, Brugada type 1. Do you often try ablation therapy in your experience? And do you have any percentage, the successful rate percentage about it?
Yeah, we are using ablation in Brugada syndrome basically in patients with spontaneous ventricular arrhythmias, so patients that already have an ICD and that have some electrical storm or frequent arrhythmias treated by the ICD, and we do the ablation in them, and the results are very, very, very promising. We have done, together with Dr. Papone in Milan, we have done a series of 135 patients and over a 3-year period, and the results are extremely satisfying. So we think that this is something that will be more and more used in patients with ventricular arrhythmias and Brugada syndrome, because it normalizes the electrical gradient that I was explaining before. When you do the epicardial ablation, you to normalize the electrical gradient between different parts of the heart, and this is very useful for preventing arrhythmias in Brugada syndrome.
Thank you very much. Thank you, everybody. And it was such an honor to hear both Drs. Dickerson and Dr. Brugada. So please, let's give them a big hand. Yeah, I think we have a break here for lunch, so thank you very much.
Lotto for participants. Bilge'yi getirebilir misiniz çekiliş için? Geliyor, okey. Brugada, can you take for the next year participant?
$1 million?
No, only for signed. Okay. Can you read?
Is it Brugada?
Wait, my spectacles. Roger Dickerson.
Wow.
Bir tane yeni hocam, bir tane yeni.
They are all
Okay.
Roger Dickerson?
Great, yes, Roger.
1 million.
Okay. This is for next year. We will send you your gift.
That's very kind.
Okay, thank you. Okay. Tamam arkadaşlar, öğleden sonra bekliyoruz inşallah dersleri aynı şekilde. Onur Bey, Onur Bey, veriyoruz. Tamam. Ona virüs şey yapıyor, biraz saldırı. Şimdi önce üçüncüyü alalım. İkinci bu ya, üçüncü nerede? Üçüncü Mehtap mı? Mehtap Kaynakçı Bayram. Evet, tebrik ediyorum. Oh çok iyi. İkinci kim? Akın Zamanlar. Akın'a veriyoruz. Akın gel. Şöyle WeWalk firmasının WeWalk projesi. Aslında siz de bizden bir ödülü hak ettiniz. İlk sosyal sorumluluk projesi ödülünü mutlaka biz size ileteceğiz. Bu güzel duyarlılık ve güzel proje için. Üstelik böyle bir günde olduğu için. Evet. Gelin hemen.
for my colleague.
Hello. I have huge pleasure to introduce Carlos Garcia Rosas, emergency physician who has fellowship with trauma and critical care in USA and is president of the Mexican Academy of Emergency Medicine and World Organization in Emergency Medicine. He will perform the lecture speech on the title Natural Disaster in Mexico. How do we respond? Thank you.
Okay.
This is the next, previous and laser.
This is laser?
Yes, laser. But
Laser?
no. Next page.
Next. Thank you for inviting me to be here. It's a pleasure to talk about one of the interest topics that we never think that will be passed again, but we suffer frequently in different countries and in different places. What we learn about the disaster in emergency medicine. Society start to work for help the people around this. So the effects of the disaster was really terrible. We never saw something before at that time, and the consequence was we lost 6,000 beds for the hospital, and they have a tremendous damage. But we need to think about why suffer the consequence in Mexico City. Well, when you think about it when the Spanish conquered the Aztecs, the Aztecs, they have built between lakes. You see the lakes, rivers, and all of this. When the Aztecs come, obviously they start to build buildings. But they don't know that below the buildings they have all lakes, and this is why shaking frequently the Mexico City. 3 years later, not only the earthquakes, we suffered the stroke for the Gulf, Mexican Gulf. 9 days in Yucatan, the hurricane whipped more than 50% of the beaches in Yucatan, and the name of the hurricane was Gilbert, and they killed more than 300 people, and the cost for this was more than 5 million of that. And then the Paulina, they come category 4 for the Saffir-Simpson, and they killed more than 400 people. And also the cost was more than $75 billion for this. they start to think about it, what is the impact, economical impact. This is why the Association of Insured Companies, they start to take care for the money, how they spend and what is the cost for the hurricanes. And this is Vilma, and they produce more than 85 refugees and more than 20 deaths. So start to produce. What is the cost of this? Tabasco, they have floods, and the cost was this. Gilbert, earthquake in Mexico. Isidoro, and the Kena and Emily, Stan, Juliet, and Paulina, they have all damage for this. The Mayan area in the part of the Caribbean and part of the Gulf, they have, when they come through the hurricanes come through the Atlantic, they go directly to this area, and this is why they suffer the consequence for that situation. This is Kena. Kena was destroyed part of the Malecón, the main part of the Vallarta in Mexico. And also they produce, one of the things happened is recently in 2017 in Chiapas, they suffered the worst and strongest earthquake. They had the magnitude of 8.2, and the duration was 2 minutes, and they produced more than almost 1,000 injuries, only 100 deaths. But the damage for this was terrible. When you think about it, that this happened, you never believe that this will be happen again and again and again, because sometimes you say, oh, again the hurricane, you want to think about it, that you need to prepare and things like that. Say, no, wait, Jose. Things happen frequently, and it's not incredible and amazing. How you can explain this? Nobody has a real concept why this happened. Well, let me tell you. In 19 September 85, I told you the situation. In 19 September 2017, we have other one, the time was of this, and then in the last September 19, in 2022, we suffer again 3 times in the same day. 32 and 37 years later, we suffer the consequence for this. The last one in September, in 2017, 19 September, was the epicenter was in Puebla. Puebla is 100 kilometers far away to Mexico City. So we prepared for, I want to tell you later when we prepared for the disaster, but it's so close, so we don't have time to be hurried to go out to the building. And they suffer the consequence in Mexico City for the middle class. We lose more than 400 buildings, and we cannot occupy more than 1,000 departments and houses because was in reconstruction. They destroy all of this. So this is happening in Mexico. In Mexico City, they suffer the consequence. And this is the trace of the earthquake in 17. But in September 19, 2022, so we suffer again. It was Monday afternoon. We experienced a strong earthquake, 7.7 Richter scale. Again, 1:05, start to shaking the air in Mexico City. So after the 1985, every year we preparing for simulation. The people was one day in 19th of September simulation because we need to be ready prepare for the earthquake. So at that time we are preparing. We not finished yet the simulation. When the people go into the buildings and start to shaking again, and the people say, well, what's going on? We finished the simulation. No, it's the real earthquake, the new earthquake. So restart again, and the damage for the Mexico City was not too hard because Colhuacan in Michoacán was too far to Mexico City. So they produce damage for the state close to the area, Michoacán, Colima, Jalisco, and Guerrero. These states reported damage, and this is the consequence for this. In 2022, 20 buildings with damage in Mexico City, and the magnitude was 7.7. So it's not too damaged that the other one at the beginning. This is why we create the National Civil Protection System to respond in case of disaster. After 85, we created in 86 the National Civil Protection System. In 1989, we developed the seismic alert in Mexico City, and we create protocol for evacuate school, governmental buildings, and public buildings. And also in 96, we create the Natural Disaster Fund, money for the people that they lose everything after disaster and need to be in the refugee, but also need money for recovery and restart again his life. In 1999, we developed the system in Mexico and we began with the 12 seismic sensor station, partially covering part of the Oaxaca and Guerrero, because 90% of the earthquakes come from this area. So this area start to shaking, so we have time to evacuate the buildings because it's taken more than 60 seconds to recover. So this is the areas that, if you see, most of them, 90% of the earthquakes come from this area. So this is the seismicity that we have in that area, and they go through 300 kilometers to Mexico City, and this is why they suffer the damage. In Mexico City right now, they have 62 seismological observatories, and they have, when they start to shaking in Mexico for the earthquake, you have between 20 and 120 seconds to evacuate the building. So it's important that you put in mind that you have possibilities to survival in case that you have. We have some alarms, like this one that I showed you, start to sing in, and you have possibilities to evacuate. We take a break. It's time to invite you to come to the World Congress, 10th World Congress Emergency Medicine in Mexico in the Riviera Maya. Absolutely, I am sure that they don't want to have earthquake. I talk with the earthquakes, and they say they don't want to present at that time, so you can come, be safe. Let me tell you what is the real situation in Mexico. So if you start to count the seconds, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So if you are in the second floor or in the third floor, you can evacuate in 20 seconds. If you are more than 4th floor, it's almost impossible that you're going down. So you see the consequence for the people, and you start to think about how you can recover these people after this. At that time, in Mexico, the civil protection start to say that it is time to evacuate it. Well, when you see the seismologic and the earthquakes, you need to be prepared before, in the time when this happened, and after. You need to recover and respond for this one. But sometimes the political, they think different like us. We create the funding for the money, and this political president, they disappear the funds, and they got the money for political parties and for his follower, and because they want to win the next election. And also we developed the hospital disaster preparedness plan with very clear objectives. Participation all levels of the hospital to take decision. We need to see the steps: situational, risk, response, rehabilitation and reconstruction. What is the situational diagnosis, treats, vulnerability and the risk of this. Sometimes they permit to build situations like this. This is why when the disaster happened, destroy all this area, kill a lot of people. We need to put signals, how you go to access for this. What is the perform essential for the funds, air conditioner, electricity, medical equipment. What is the funding, cools, walls, beams and slabs. All staff should be involved in the hospital situation because they are priority to go this way. We need to take care for the critical areas, emergency room, all lab, radiology, ICU, and all these things. The organizational, to reduce the effect is really important, yeah? And we have a structural vulnerability, but also we don't have a structural vulnerability, and we need to localize the situation. What happens when you don't follow the rules? this is happening. In Tula, 90 kilometers far away to Mexico City, they don't follow the rules. And this is, most of the lands they give for the government, and they are not really good lands. And these guys don't follow the rules, and this is why when they have a power fail to the rain and flooding, they produce damage for the emergency room and kill more than 70 people in that situation. So the vulnerability for organizational and the functional situation is really important, because sometimes in the emergency room, the vulnerability is all the time we are overcrowding, plus when you have disaster like this. So we need to see what is the response for the characteristics. Is real dynamic and variable? Response plan is not a job for the desk. It's an active visited and group session process for institutional and intra-institutional situation to develop. Mitigation, no cost long term. Pay money and lives if you don't treat correctly and you don't respond correctly. The mitigation between 1981 to 1996, they in Latin America was in operate more than 93 collapsed hospitals and more than 500 clinics. And they also produced more than 3,000 million in losses for the healthcare. So the cycle of the disaster is disaster, poverty, poverty, disaster, and degradation of the environmental. So you need to be careful. When sometimes you put the signals and you put the escape to the roofs, and the people doesn't understand, they put like this. So how you can evacuate it if they say fix it, the exit? So remember, the Hospital Risk Management Committee is responsible for the vulnerability, the studies, identify and implement the mitigation, and follow the previous stabilization methodology and work schedule. Remember, you never know when is the next disaster will be. Be alert and be prepared. Because when they suffer the consequence, you cannot respond adequately and you can help the people in good situation. Remember, the way is Mexico. We'll see you in the Congress, World Congress in Emergency Medicine. 36 years practice emergency medicine in Mexico.
Thank you so much, Professor Garcia, for this extremely important lecture and for the invitation of Congress. And I hope if we arrive to this Congress, we will be not patient concerning to those topics which you say. Thank you so much.
Well, it's a pleasure to introduce our next speaker, Lucas Sampa. He is president of the Polish Society of Disaster Medicine, worldwide vice rector for the Science and Cooperation in Maria Medical Academy in-house, and is visitor professor for Baylor College and Medicine. Thank you, Dr. Lucas, for being here.
Thank you so much. I know that my surname is tough to talk, but Sharpak, but thank you. First of all, I would like to thank you for the opportunity to be with you on this extremely important Congress worldwide, because it's, I suppose, the biggest Congress in this side of this part of the world. And as Professor says, I'm Vice President. I'm President of Polish Society of Disaster Medicine, so this is important to me a lot. I want to talk to you about the modern airway management techniques in the emergency medicine, and I want to show you some opportunities, and I want to show you also some dates, some data from other articles and from different databases, so you will, I suppose, know how to use them, and I suppose in the future you will use some alternatives to direct laryngoscopy. Of course, conflict of interest statement, I don't have it in this presentation, so we can, I suppose, start. As you know, airway management is a cornerstone of emergency procedures, especially in the critical care patients when we have small time to secure the airways and conduct other medical procedures. And the same, as you know, experience in endotracheal intubation plays a huge role, especially in the case of direct intubations using standard laryngoscopes with Miller or McIntosh blades. However, analysis in the effectiveness of airway management in emergency medicine has indicated need for several actions on many leads, and the first one is staff training. We know that the number of the endotracheal intubations and the number of new devices of airway management realistically performed, and emergency medicine, emergency physicians, paramedics, nurses are not able to do the same number of endotracheal intubation as anesthesiologists. So we should use alternative methods and possibilities to perform those endotracheal intubations, to have the insurance that we, in this critical situation, will perform successfully the endotracheal intubation. So, for example, we can use, of course, medical simulation and high-fidelity simulators. The second part is that under emergency medicine, we perform endotracheal intubation in urgency, and actions taken, a lot of sufficient assessment, and the emergency patient's preparation is not the patient is not preparing, because we do in the resuscitation circumstances, we do in the severe acute respiratory distress syndrome, so we don't have time to pre-oxygenate this patient, to perform optimal options when we're talking about the light, about the visibility of the glottis, etc. So we should use alternatives. When we're talking about successful of the endotracheal intubations, of course, we can talk that the endotracheal intubation is a gold standard of the airway secure under the ICU or operation theater, and the anesthesiologists are best prepared for this procedure. However, as you see on this slide, in study by Day at Cooperations, they compared the CMAC video laryngoscopes and McIntosh laryngoscopes under patients in ICU. And you see that the first attempt success rate of the intubations, for example, was 84%, and the 84% was not for direct laryngoscopy, but for video laryngoscopes. For direct laryngoscopy was only 57%, so if we have difficult airways, we should use video laryngoscopes, and even anesthesiologists do it. For example, in Poland, in each resuscitation table in the hospital, starting from the emergency department, then ICU and operating theater, we have video laryngoscopes, and we should use it, and we use it. The second study, which you see on this, was performed under the elective surgery in general anesthesia, so it's also conducting among anesthesiologists. And in this study, for example, authors compare the McGrath, TrueView, and McIntosh, so they compare two video laryngoscopes and one direct laryngoscope. However, the situation was the same as the previously. I mean, the duration of laryngoscopy was significantly less with McGrath group compared to McIntosh, or even compared to the TrueView. So even if we have some video laryngoscopes, we can expect also some differences between efficiency of the using of those devices. The second thing important from this study is that the Cormack-Lerain grading was significantly better with the video laryngoscopes than direct laryngoscope. So if we know that we have we can expect difficult intubation, difficult airways in the patients, we should focus on some alternatives to perform fast and efficiency intubation at the first time. And in this study, you see that the first attempt success rate of intubations was 97.5% for McGrath, 100% for the TrueView, but only 87.5% for the direct laryngoscopy. So it's not good, especially when we don't have time to work with these patients. Summarize this stage. I want to talk about one meta-analysis, because as you know, meta-analyses are are the most important studies in the pyramid, in the hierarchy of studies, in the pyramid of studies. And for example, Vargas in meta-analysis conducting 97 articles show that the risk of difficulty when we use the video laryngoscope is smaller, relatively smaller than when we use direct laryngoscopy, for example, as I said previously, with the Macintosh blade. The second part may be more interesting for you because it will be emergency department. In emergency department, we have the same situations. For example, in study by Sackles, the first attempt success rate with the video laryngoscopes, in this time CMAC video laryngoscope was 97.3% and only 84.4% for direct laryngoscopy. And when we're going forward, EMS. In EMS we have even worse results of intubation because we have different circumstances when we can intubate. We don't have optimal lighting. Sometimes we perform endotracheal intubation in the rain, in the snow, or even lying near the patient. But Breman, for example, showed that endotracheal intubations performed by nurses, ambulance nurses. They perform endotracheal intubation with the first attempt success rate at the level of 57% when they use video laryngoscopes and only 48% when they use direct laryngoscope. And the same, to conclusion this, there was a nice meta-analysis conducting direct and video laryngoscopes performed by Saviano et al. And they show that the video laryngoscopes, of course, when are using by the physicians with high experience with direct laryngoscopes, don't perform any advantages to the direct laryngoscope. But we need to know that in EMS as well as in emergency department, mostly working emergency physicians, paramedics, nurses, not having the experience, huge experience with direct laryngoscopy, so we should focus on some advantages and use video laryngoscopes. The same, of course, when we have the operating room, we have optimal conditions to perform endotracheal intubations. We don't have it in the emergency. We sometimes perform the intubations lying with the patients, the second one during performing chest compressions or with manual stabilizations of trauma patients. Sometimes we intubate during the moving of ambulance to the hospital or even performing those intubations at night on the road. But when we're talking about the efficiency of different methods of video laryngoscopy, we can also should focus on the training process. And for example, here you see that in Lee et al. Study, participants need near the 120 endotracheal intubations to be sure that the success of first intubation attempt rate will be above 85% in the emergency department. For example, in Gu et al. Study, they need only 20 intubation attempts to achieve success rate at the level of 80% when they use video laryngoscopes. So we see the disproportion between the between the time of learning different methods of intubating. When we're talking about video laryngoscopes, of course, we can talk about many laryngoscopes. We can use different scales. We can use different classifications. But for me, this is one of the this classification speaks to me a lot. But I don't want to talk about all laryngoscopes. I will focus right now on the McGrath, which is well-known laryngoscopes, and I hope you use it in your practice. Of course, we can use laryngoscopes in different situations, and here on the slide you have data from the comparison of the McGrath and the Macintosh laryngoscope in different circumstances. The first one is under general anesthesia, and you see that authors compare different laryngoscopes. I talked about it previously, but you know that firstly, the glottis visualization is better with video laryngoscopes. The second part, the number of attempts needed to secure the airways are also lower. But the important thing for me is also the last point, the trauma. The trauma is the adverse events of the endotracheal intubation. And for example, in this study, we see that only in 2 patients there was obtained trauma during endotracheal intubation when patient was intubating with TrueView, in 20.5% when we're using Macintosh, and in de facto in McGrath laryngoscopes we don't see any trauma. So we can use it especially in different situations, such as the second point. I mean for example, endotracheal intubation among patients with neck manual or cervical collar stabilization. So we see the possibility, we see the advantages of the video laryngoscopes. The same when we're talking about, for example, resuscitation, because according to the resuscitation guidelines, you know that the key point of resuscitation process right now is the minimalization of the chest interruptions. So using video laryngoscopes, we can even intubate patients under continuous chest compression. I want, at the end, talk about some alternatives, some new alternatives, because as you know, TrueView, GlideScope, McGrath, you know those devices, because they are from many years on the medical market, and I hope at your hospitals. However, we have also some new nice devices which we use, for example, in Poland right now in EMS. I mean the V-scope, and this was the first study conducting in the scenario when the patient has the out-of-hospital cardiac arrest and was intubated by paramedics wearing full protective personal equipment. So, as you know, doing something with full PPE, it's difficult. But when we use some alternatives to direct laryngoscopes, we see the decreasing time of the needed to perform endotracheal intubations. The second thing is that we see, the second thing is that we see better glottis visualization when we're talking about Cormack layering rate or percentage of glottis opening scale. We see the same. And of course, these devices has 2 versions. The first version is for adult patients. The second one is for pediatric patients. However, we don't have right now clinical study on this because it's relatively new, and I obtained this laryngoscope 2 months ago for studies and for training. However, we perform simulation study in this situation. We perform simulation study in 3 scenarios. First is normal airways. Easy. The second one and the third one is tongue edema and continuous chest compression. So we can use the term of difficult airways. But as we see, the time at the first scenario, normal airways, was near the same. However, in the difficult airway, we see increasing disproportion between time of intubating with V-scope and with the Macintosh laryngoscope. And the same when we're talking about FPAEs. So first intubation success rate. In normal airway, it was 100% in each group, and in the difficult airways, it was higher in the V-scope and, of course, smaller when we're talking about direct laryngoscopes. So video laryngoscopes are a good alternative, and this is a huge question. Should we use intubation techniques as alternatives to direct laryngoscopy? For me, in my perspective, yes, because we don't have such an experience as anesthesiologists in direct laryngoscopy. Besides, you saw that slides that even in ICU, the efficiency of direct laryngoscopy is not each time 100%. So we can use it, we should use it, and we should learn how to perform endotracheal intubation even on simulators, even on cadavers, and to be sure that when we have the situation when we need to perform patient in emergency medical service or in the ER, we do it correctly and we do it with high efficiency. Thank you.
Thank you, Professor Lucas, for your excellent presentation. And we want to come to the next speaker is Dr. Serey Emre, ATIS, is Carabin University, Associate Professor for Emergency Medicine, and he wants to talk about what is the topic?
He will talk about missed ischemic stroke diagnosis in emergency department and young patients.
Thank you, Dr. Serey, to be here.
Thank you. Thank you, sir. Hello, everyone. I'd like to speak about the missed ischemic stroke in the emergency department. First, there is no conflict of interest in my presentation. Ischemic stroke, many conditions lead to a reduction of blood in the brain, so results tissue damage. The failure of diagnose an ischemic stroke is a missed opportunity for the intervention and causes disability or increases costs. So what are the reasons for a missed ischemic stroke? There are many articles about this. This one is a retrospective chart review. Study population was 465 patients. The term missed used when if the practitioners in the emergency department didn't initially consider stroke on the term was used, or if the patient missed the thrombolytic therapy. Also missed term is used if emergency department physician consult this patient to the neurology, but neurologist didn't thought that this was a stroke patient. In the study, 103 stroke patients were misdiagnosed. The average age was 72. All the patients had high blood pressure, and there is no differences between the comorbidities. In the combined data for missed strokes, 31 of patients had a history of stroke. In comparison, patients who were diagnosed stroke, 19 had a history of stroke. For missed stroke, only 8 were triaged as stroke cause, so the stroke code triage is important for diagnosis of the stroke. In univariate analysis, headache, nausea, vomiting, dizziness, seizure, syncope, and also difficult walking is important for missed stroke, associated with missed stroke. In binary logistic regression models, nausea, vomiting, dizziness, and positive stroke history associated with missed strokes. Conversely, focal weakness, vision change, gaze preference, and dysarthry associated with the correct diagnosis. Posterior circulation strokes were missed nearly 3 times more than anterior strokes. Another study from 2016 again. This study contained a larger population, which is 2027. 283 patients were missed. Focal weakness and numbness and speech abnormalities were more likely in the diagnosed group. But the decreased level of consciousness more in the missed group, and like the previous study, posterior stroke was more seen in the missed group. This is the same as the first study. Patients with missed stroke were more likely to have nausea, vomiting than those diagnosed group. But in contrast, the previous study, prior stroke was not an independent factor for missed ischemic stroke, but younger age and decreased level of consciousness is associated with missed stroke. Another study is a case control study. Study population was 157. There was no differences in age, gender, and comorbidities, same the previous studies, but the level of consciousness, dizziness, syncope, nausea, vomiting, memory disturbance, and vertigo were more common in the missed group. Like the stroke code, the positive fast examination was lower in the missed group. So we really need well-trained emergency medicine service or staff for taking the history. Also, misdiagnosed patient had a lower ED triage code. There are also meta-analyses about missed ischemic stroke, one of them from 2017. In this meta-analysis, increased risk of misdiagnosis was associated with younger age, imprecise history, posterior circulation strokes, and lower NIH stroke scale. So for the last, I have to say, young people may have a stroke. Posterior circulation symptoms such as nausea, vomiting, dizziness, vertigo, and syncope may be associated with stroke. Headache, seizure, reduced of level of consciousness may be sign of a stroke. We need to take a full history. Examination should contain posterior circulation and stroke scales are not weighted for all the stroke subtypes. Not only we doctors, but also many branch of science are still trying to find a way to early diagnosis of stroke. Thank you.
Thank you, Dr. Daray. If you have question, please go ahead for the speaker. Yes, sir.
Thank you very much to all three speakers for their nice presentation and sharing their experience with us. The first question is for Dr. Emre. Thank you very much. This is one of the missed problem we have, missing the stroke in emergency department. My first question was that, how did they recognize these missed strokes? Because the patient came to emergency department, they did an examination and have, they used some diagnosis violence, and the patient discharged from the emergency department. So how they diagnose the missed strokes? Did they call the patient again?
Sometimes the patient admitted again the hospital, but sometimes later time. But sometimes they searched about the patients. This is different with different studies.
Thank you very much. Because this point is maybe confusion. The patient first came to emergency department with some symptoms, and you said this patient does not have stroke. You discharge the patient, but the patient came to emergency department secondly or thirdly or fourthly time. I mean, maybe 1 month later, 2 months later. So it is difficult to say. The first presentation was stroke. So there's a confusion here. Thank you very much. My second question is that, do you have any suggestion or do you recommend us for all the patient who has, you talk about some symptoms. Do you suggest us to have, central weave?
I think that we need maybe new scales for the posterior circulation, because not only GCS score but also force scores and other scores is not weighted for the for posterior stroke. Maybe we have to develop another stroke scale for the posterior circulation.
One question for you, Dr. Carlos. Thank you very much. You know, I will figure out about very two important point for me that you mentioned in your presentation. The disaster doesn't have any mind. They doesn't have any eyes, and they doesn't have mercy. But we have. As a human, we have our eyes, mind, and mercy. So the precaution that you mentioned many times should be done to protect ourselves and our community and society from the more injuries of the disaster. Thank you very much. We have very good experiences. How did you achieve to disseminate the awareness, the importance of the training and teaching to the community in your society?
Well, when we started in 96, in 86, 87, I started to training nobody believed that we have a new earthquake. So they don't pay too much attention, but when they start the other disaster, so we organize the preparedness for the hospital, secure hospital, and we need to prepare. So we start to prepare all people inside of the hospital, but also we talk with the people that they offer pre-hospital care. Because in the last earthquake that we have in this year, in 22, the most people was involved was the youngest guy. The youngest guy for the school, they go to hell because the earthquake was in the middle class of Mexico City, and many of these students, they are training in certain response in Mexico City to disaster. They organize social people, they organize how to take care for the food, how to take care for this, and other things. And also, in all school, it's obligatory that in the public building also it's obligatory that you are at least 3 or 4 times evacuation and simulation for all buildings. So you have civil protection, you have school protection, you have training in a hospital, you have also training for the emergency physician to help how you can respond in case of the disaster. But it's hard to teach all of them because every 3 years or every 6 years that we change for the politicals, they restart again the things that we did before. For example, we have the social security and we have other system to respond, and this president disappeared the fundus. So if you don't have money to prepare the people for training, for program, for response, it's hard how you can help the people that they lose everything. For example, you work in a public hospital, or you work in the public building, you go outside for work, when you get back, the building disappears. So you don't have anything. So you need to support for the beginning to restart again your life. So the fundus that we have and we create was to help the people when they suffer the consequence. So it's multidisciplinary, the group that need to work and to prepare ready for the response for the disaster. This is how we did in the last 30 years. Yes, yes, sir.
Hello. I have a question about airway management education. Do you think that video laryngoscopy...
Can you...
yes?
Close. Okay.
Do you think that video laryngoscopy is effective of training either video laryngoscopy or direct laryngoscopy? Because we know that video laryngoscopy is, with video laryngoscopy, it is easier to see the anatomic structures.
Firstly of all, when we train, when we perform, for example, training in Polish Society of Disaster Medicine in the field of airway management, we each time start with the direct laryngoscopes because it's worldwide gold standard right now, and I suppose it will be still in next decades. However, if you know and you see this in direct laryngoscopes, it will be easier even after then when you use video laryngoscopy. Other way, if you start only from the beginning with video laryngoscopes, you can see the situation when, for example, you don't have it or the battery will end in the video laryngoscopes, and it will be problematic. So you should have some alternatives, but you should have also the background with the direct laryngoscope. I'm not fan to use video laryngoscope in each intubation, but if I know that I probably will have some troubles with the endotracheal intubations, with the airway management with patients, especially with patients with trauma. In this situation, I put the direct laryngoscope on the table and use the video laryngoscopes. But I'm fan of this, that we should train both methods at the same time, and this will increase the ability to use different devices even in your clinical practice.
One comment. Also, when you compare the laryngoscopy, direct laryngoscopy, with the non-invasive methods for oxygenation, because I saw the one slide that you showed, each two, they was successful, the intubation in the emergency medical system. Mm-hmm. It's 48 and 50 something. Is one yes, one no. So I think at that time you need to compare that I don't know in Poland, but most of them people in the pre-hospital care in Mexico is not a doctor, is a paramedic. So the training that they have is completely different than the emergency physician in the room.
Yeah, I fully agree, but this study which you mentioned was performed about ambulance nurses. And we should know, I don't know what the training process looks like in this country from which the study is, but for example in Poland, from the beginning paramedics are trained with the direct laryngoscopes, and at the end of their career as a students, we give them video laryngoscopes to play with those devices and be prepared for everything. But for example, in Poland also right now the anesthesiologists, the emergency physicians spontaneously only working at the EMS. As I say, from the beginning, we need to find some solutions to increase the efficiency of endotracheal intubation in different situations, because you saw that even in ICU, the effectiveness is not 100%. Then in emergency department, we use the endotracheal intubation not as a planned procedure. We use it fast. We use it in life-threatening situations. And the second thing is that in emergency department, we can call, for example, on-duty anesthesiologist or senior doctor, and he will perform this. But in pre-hospital care, we can focus only on themselves. We should perform increase our skills to use different alternatives. Besides, as I say previously, when we're talking about endotracheal intubation in COVID-19 patients, we use the full personal protective equipment. And we know from different studies and from our perspectives that we should find alternatives because, for example, of course, direct laryngoscopy decrease in efficiency, but the same, for example, when we obtaining the intravascular access or performing chest compression. So I suppose in each field, not only in the airway management, we should find some alternatives and we should find our roads.
Thank you, Doctor. So we have time for one question more because we are over the time. If somebody make a question. Okay, if not,
maybe I have a question to Professor, because you're talking about the organization of the trainings, etc. But I'm curious in the Mexican perspective, how often should be performed the exercises of the rescue teams and emergency department, EMS, firefighters, etc.?
Well, the emergency physician or the emergency doctors work sometimes in combination for the pre-hospital care. It's separate fields. The pre-hospital care was given by Red Cross, ERUM, the police, and we sometimes prepare every 1 or twice per year to organize something. But in the hospital, the emergency room, they have a special training for respond for in case of the disaster. But the people from the Red Cross and the ERUM, is the police department, they are training frequently to evacuate patients and rescue patients when they have in the troubles with the that I showed you. In the earthquakes, although in the hurricanes for the cities that was exposed to this, like in the beaches, in the Caribbean, and in that place.
But you perform the exercises for all organizations together? For example, to perform the chain of the transfer of patients from the outside to the, then moving with ambulances, then going to the emergency department?
We do two times per year. The simulation is obligatory for the public and for the school and for everybody, 2 times per year. It's obligatory. The rest, you can do it, but every group different.
Okay.
I don't know if is this the
thank you so much.
Okay. Yeah?
About this point? May I have a comment about this point, about your question?
Yeah.
Thank you very much. To me, especially for the countries who are facing many disasters, at least for the hospital, regarding only the hospital, not for the other partners, at least we have to make one simulation, table simulation training, and one simulation, scan simulation, at least, for the hospital workers, not for the other partners, for the doctors, nurses, and the paramedics. This is my opinion that we are doing in Turkey also.
Yes, it's okay, but you put the rules. For every hospital, we put the rules. And
should be.
Well, should be, but we put the rules. If you don't follow, this is exactly the example when I show you in Tula. The Tula is the name of the hospital. They don't follow the rules. They don't pay attention for the special areas like the emergency room, oxygen, OR, or whatever, and they suffer the consequence. The people die because they don't have oxygen supplement, and they die because they cannot breathe. So this is the consequence for they don't follow the rules. When you put the plan and the program, you give all institutions, this is the rule, this is what you need to do, this is how you can train in. But sometimes the people doesn't understand or don't care about this. They are in other different situation and they think that never happen again. And you see the history. 3 times the same day, almost the same hour. 1 hour or 2 hours different and 1 in the morning. It's amazing. And we start to looking for explanation. Why happened the same day 3 times? If you see Hollywood, they don't want to put something in the same day. They put in different
I think it depends how you carry it. Because, for example, I just give a very simple and very known example. For example, during the COVID period, it was forbidden to wear, mask, and everybody use it. Everybody's used. So it depends how you carry the situation, how your government, how the related, management are caring about this issue. If they care too much, they can achieve it. They can make a very good and high quality of the awareness of society.
Yeah, but when the measures is wrong for the government or for the Secretary of Health, the response for the public is wrong. We have, the pandemic show us the examples.
I don't mind about the politician, I'm talking about as a health staff.
Yeah, I'm talking about the same. If you tell the people that they need to training and doing simulation every 2 months or every 3 months for training the kids in the school. Now, I don't bring one video, but now in the school, when they start to ring in the bells, the kids
3, 5 old, 6 years old, everybody go to the safe place, start like this, they be prepared in the school. So in the public, sometimes the public say, oh, I don't care, it's simulation. I was in the last one in September, I was in the public office for any administration. This guy take it at least 10 minutes to evacuate it and say, 10 minutes, don't worry. Later, they have the consequence because you have between 20 and 120 seconds to get out. And if not, this is the consequence, I think. Well, thank you very much for attending the meeting, and I enjoy. cause of mortality and morbidity around the world. They kill more than 6 million of people per year, and 10% of all of these patients, they die around the world, and potential preventable deaths. The trauma and coagulopathy induced is multifactorial. They include the shock, the acidosis. They also lose the coagulation factors and hemodilution and they have 3 different ways to mechanism produce. One is the hemorrhagic shock, will be lose clotting factor. The second one is the hypothermia, and the third is the acidosis. Produce also this one. Also, they have comorbidities, pre-existing factors that they produce the trauma. Most of the damage they produce, they lost the blood, produce the consumption of the factors, shock, hypoxia produce acidosis, and the acidosis produce coagulopathy. And also the hypothermia that I show you, and dilutional coagulopathy when we start to do that. The coagulopathy is modified for the trauma-relation factors as brain injury and other cofactors that I told you before. And they have 3 severity levels of this, and as related with the niveles of the fibrinógeno. If the fibrinógeno level is minus than 1.5, is level 1. Second is when the fibrinógeno is less than 1.5, and the NRI is more than 1.5. So the third level is when the dose of this one plus the platelets is low below 100,000. The 3 principal causes of death is in trauma is the road traffic, suicides, and homicides. And the trauma is related in the United States. 60% of all deaths under 45 years old is related with the trauma, and the hemorrhage is the principal cause of death. About 35% of all preventable injuries for mortality. And 1/3 of these patients who presented to the ER with severe bleeding show signs of coagulopathy, and is 4 to 8 times more likely to die the next 24 hours. During the Vietnam and Korean War, they found that the soldiers sustained extensive damage and developed coagulopathy disorder. At that time, Simons wrote some papers that presumed to be associated in disseminated intravascular coagulopathy. The last decade, the specific pathology was associated with the bleeding, follow the trauma, and increase the recognized and the management strategies, and they start to resolve the problem. The history about this in the 70s, such coagulopathy is reversible for the fresh frozen given, and as related with the massive injury and massive blood transfusion. And the mechanism at that time is obscure. They don't know very thing about that. And over the years, in the 80s, the gunshot and the stabs and the all trauma produce microvascular bleeding, and the experimental for the surgeon start to reduce the time that they are in the operating room and focalize more in the coagulation, and then for the time they spend in full repair the injuries. To understand a little bit more and remember how this is going on, you need to see what is the role of the fibrinógeno in the clot fracture. You need to know, to understand what is the initial information that every emergency physician needs to know about the trauma patient, and what is the level of the fibrinógeno, what is the platelets count, and is the patient on in treatment, what treatment and what antithrombotic they are using. This is how you need to remember what is the role of the fibrinógeno. The factor 10 go to activated factor 10 and 5, and they activated proton mitoprotein, only produce activation of the fibrinógeno for the fibrin, and they produce the polymerase of the fibrin. So once activated, the platelet express the fibrinógeno receptor. The wash is important to create the fibrin mesh clot, because it's important to reduce the time of the bleeding. And also in massive acute injury, the conversion of the plasminógeno and the plasmina is become dysregulated by the system of the level. So the trauma-induced coagulopathy by hyperfibrinolysis, hypofibrinogenemia, and is associated with we start to resuscitate the patient because they give more solution and they can produce the hemodilution. I told you a couple of minutes ago, if you remember, you need to be in the 10 World Congress in Emergency Medicine. We have 20 years organizing Emergency Medicine Congress about the World Organization in Emergency Medicine. So I'm waiting for you. He's right in the corner. In the Caribbean, he's right there. So what is the reversal anticoagulation and the management of this patient? Well, if you see this paper, they show that the management of massive transfusion trauma patients are improved because they understand better what is the damage that they produce the coagulopathy and the limitation of the use the crystalloides infusion because you don't need to go for the other side because remember, they have cofactors, they produce more damage than benefit when they use too much. And the other case that you need to know to mitigate the lethal triad, acidosis, hypothermia, and coagulopathy. The treatment for this includes that the tranexamic acid, fresh frozen, cryoprecipitase, and coagulation factor concentrate. So this one is the prothrombin concentrates and fibrinogen concentration. They help because they produce more benefits and they don't produce too much side effects such as respiratory distress, sepsis, or organ failure. And they are also used immediately available. You don't need to test the group. In this multi-transfusion are currently changed in recent data showing that if you early use an aggressive transfusion intervention, the resuscitation with blood components decrease the mortality. This is important because sometimes the people is afraid to use these components and they take time. The ideal for the plasma, platelets, and cryo is not precise, but the current data support that if you use one, and one, this is the benefit that is one. Also, they can use it in dual target coagulation. You can use fibrinogeno in the patient right there. And in this paper, the guidelines for the management of major bleeding in the 5th edition, in the last one they published, they say that they can use initial management of the patient with massive hemorrhage. You can use fresh frozen plasma, and also you can use fibrinogeno concentrate or red blood cells to more benefits. In this study, CRASH 2 and 3, they subject more than 25 patients, and they use tranexamic acid 2 grams. One is in placebo, and the best result that they showed is when you use before 8 hours of the damage, because the benefit is that all of these, the result showed that the all causes of mortality was reduced 14% versus 60% with placebo. And the bleeding-related mortality reduced 4.9 versus 5.7%. It's important to normalize the fibrinogeno. The doses is the fibrinogeno correct, detect, and the rotten, and increase the close strain and the firmness of the coagulopathy. And in the United States, they use it more frequently. The cryoprecipitados is primarily used and contain more von Willebrand and factor 13, and the fibrinogeno concentrate are used when the cryo is not available. And also in surgical trauma, you can use on-site in some therapies, and the systematic use of the tranexamic acid could be better. The high doses of this, you don't need to increase more than 6 grams and may result in increased incident side effects like seizure. You have available storage use, traditional use, and also the fibrinogeno is only concentration in normal plants that need large quantity of this. This is why the coagulation factor concentrates in the fibrinogeno concentrates is available in one globally for products currently in other countries, and they help to reduce the bleeding. So this is the decision tree for this. If you have important bleeding, yes, you send it for test, rotten, TEC, PT, and PTT. You need to maintain the hemostatic, and also if the fibrinogeno is less than 1, you start the fibrinogeno concentration. Platelets count is less than 100, you use platelet concentrated, and if you have other one, you can use it. So use the multi-strategic. You need to resuscitate with fluids, but be careful to go on the other side. Antithrombolytic tranexamic acid is the important. And also you need to have testing the viscoelastic test and Rotterdam test, because if you have all these tools right there in the point of care in the emergency room, you have more possibilities to take and make more decisions in case that you need. In this paper, they review in all Europe the guidelines for initial treatment of the bleeding. They guidelines generally agree, because every country had different concepts. So in this paper, they showed that the administration of the tranexamic acid as soon as possible, that I told you before, is okay. They follow the direction for the frozen fresh plasma, red blood cells to prevent and treat the massive hemorrhage is okay. All European guidelines recommend the use of the fibrinogen supplementum and cryoprecipitated level when the cryoprecipitated is low, and the use of the PCC and the T treat in the patient with the coagulopathy and trauma, and the patient are in treatment with the BK, they are not agree with use this different with the other each country. But they are agreed that also, they are not agree also that when they activate recombinant factor, is not recommendable for the first line of the therapy. So in this, sorry about this slide, but I want to reduce the concepts. In Europe, the guidelines show you what is the elements that you use for fresh frozen, red blood cells, blah, blah, blah, in Europe. Czech Republic, Slovenia, they show what is they use it. Sweden, Germany, and Spain, also UK, and they use different elements for that. So recommendation treatment in the guideline, they show that the tranexamic acid administered as soon as possible. Within the 3 first hours of the trauma, they get the better results for the patient. They use it for the loading doses, is 1 gram, and then 1 gram for the next 8 hours. And also for the fibrinogen concentrate, they use it with the red blood cell administered while you are waiting for the result of this, and repeat the doses according to the adjusted of the viscoelastic testing. And the prothrombin concentrate, also you can use it if the fibrinogen level is more than 1.5, or if the prolonged clotting time is more 90 to 120 seconds, and this is the dose. In conclusion, patients need to be transferred directly to the trauma center. Sometimes the patient is close to any hospital, but you don't need to send it for the close hospital. The close hospital, they don't many times resolve the problem. So you need to send directly for the trauma center. They want to resolve the old problem that they present. The use of restricted volume during the initial resuscitation is important. If you remember a long time ago, years ago, they start to use it 2 liters of the solution or 3 liters for the solution, and the patient, they have cardiac fail, renal fail, another problem, and they have suffered the consequence. So determine what is the coagulation profile with viscoelastic assays is available. The use of the tranexamic acid as soon as you can, that I told you, 1 loaded gram and the other one in the next hours. And the use of the fibrinogen and coagulation factor concentrates early to improve the outcomes. The appropriate management of trauma patient with massive bleeding and coagulopathy is changing because they recognize more the situation for this happen. Remember, time is life. And also the trauma patient need to be resolved for the multidisciplinary group. Not only one doctor can be treated. Sometimes you need to treat it, you recognize, you made the diagnosis, but you need the surgeon to come to laparotomy because they have liver or any other damage surgery, and you need to send it for that. Best practice of use of the blood products during the resuscitation continue to involve more guides and go directed to the strategy. The identification of the management is important in patients that come to the emergency room. Also, it's important that the state-of-the-art clinical practice guidelines should improve like conference like this. You need to identify what is the source of the bleeding, minimize the blood loss, the hemodynamic about it, solve quickly, solve the problem well, be patient. Sometimes you need to be patient how the patient is the evolution. Understand what's going on with the patient, because sometimes we see that the patient is bleeding, but we don't know where the bleeding comes from, what is the sources. So you need to understand more about us, and then you need to be ready again for start with the new patient when they come into the emergency room. Remember, the emergency room never stops. 24 hours, open the door, doesn't matter you have full overcrowding every time you have patient over there. This is historical picture because now Peter Rosser passed off, and this is Judith Intinali, one of the pioneers of the emergency medicine in the United States, Peter and Judith. And this is how we start in 1986, how we start the new areas that we name it resuscitation area, and the base, how we started 36 years ago, and now we have different, and now the concept changing over the years. And remember, the future is Mexico. You can see the next conference. And thank you again for inviting me to be here. It was a pleasure to come to share with you face-to-face after the pandemic, and I hope we can see soon, and take care, and thank you.
Thank you, Dr. Carlos. Next is Dr. Ayman Al-Mayyar, Director of Clinical Research and Development in Trauma and Vascular Department at Hamad General Hospital, Qatar.
The next page, previous page, and later.
Okay, thank you. Good afternoon. Again, I would like to thank organizing committee for inviting me for this great conference. I'm going to present one of our study from Hamad General Hospital in Qatar to address the impact of the short and long ED time on the trauma patient. And this, as Dr. Carlos said, the emergency is always busy. So we want to address what the impact of staying short in the emergency versus those who are staying longer in the emergency. So emergency department crowding is a global healthcare challenge because there is imbalance between the patient load, it's coming too much patient, and the ED capacity, how the capacity of the hospital, and also the availability of the in-hospital bed. So the need for patient triage and radiological imaging and laboratory analysis, multi-specialty consultation, especially for polytrauma patient, this will affect the flow and the time the patient will stay in the emergency. So therefore, ED length of stay has been anticipated as a quality indicator and benchmark for the emergency healthcare service. So you can assess the quality of the service you are giving to the patient by looking for how the patient in the emergency, how long he stay, and what is the service can be done for him. And also, what is the impact? The patient who stay shorter is better or stay longer is better. This is the dilemma, especially among trauma patients. So delay to transfer trauma patient from the emergency had a major burden on the emergency service. So polytrauma, many people are around, so this will affect also the flow in the emergency and the easiness of the work. So we sought to explore the factor that could affect the ED length of stay and its impact on the hospital course and outcome in a level 1 trauma center. So we run our study on 7,000 patients, and the patients were categorized into 4 groups. Patients who stay less than 4 hours, and patients who stay from 4 to 12 hours, and from 12 to 24 hours, and those who stay in the emergency more than 24 hours. Just to remind you, all these patients who already is for hospitalization. Do know. Great. You can see here we are more younger. They are 29 years old, so are younger, which is reflected the cause of admission, which is a motor vehicle crashes, which is very common in our area or even everywhere. So more are males, and the ED time, the ED service, the transportation to the hospital was 66 minutes for those who stay shorter in the hospital, but it is longer for those who stay more in the emergency. This will reflect that those patients are more severe, so they transfer quickly to the emergency, and they will stay less in the emergency because maybe died or may need to rush to the operating room or to ICU quickly as much as they can. And you can see also for trauma code activation, the trauma code activation level 1, 50% are staying less in the emergency, which reflect also on the severity. T1 is the severe cases. So they stay less in the emergency because they can go immediately to the operation or for the ICU, or they may die. But you can see also that the comorbidity, like hypertension and diabetes, operating room or intensive care, and the injury severity score are high on this patient. And they also have higher shock index and sustain more head injury compared to the other group. We also note that there is a correlation, positive correlation between staying in the emergency and the GCS and TRES and RTS, which are indication or indicator of the severity of injury. And this chart is taking categorizing patient per hour. Each hour, what is the mortality for each hour staying in the emergency? You can see in the blue, within the first 4 hours, each hour the mortality is higher. If you stay 1 hour, not like the 2 hours, 3 hours, 4 hours, up to 4 hours, then the mortality reverse. Patients stay longer, and the ED, the mortality less. What is the predictor of short stay in the emergency? We can predict those who stay shorter. What is the criteria? The initial hemoglobin is low. Gender, they are more male. The ISS, injury severity score, are higher. GCS is lower. Shock index is higher. And the need for blood transfusion is more. So this is the criteria you can predict which patient will stay shorter in the ED. But what is the predictor of mortality? The predictor of mortality was the age, ICS, shock index, head injury, T1 activation, blood transfusion, but not the length of stay. The length of stay associated with mortality, but it is not independent predictor, because there is another factor you have to think about it, which is the ICS and shock index and so on. So this is a tricky point here, that staying shorter, mortality is high, but it is not independent predictor. The limitation of this study, this is retrospective data, but also the definition of early or delay length of stay in the emergency is not consistent in literature. Some say 4 hours, some say 6 hours, some people say 12 hours, so there is no consistent what you call short stay. How many hours to say short stay? Also, the lack of time the patient spends in the imaging, for CT scan, for example, consultation, moving between the corridors, we didn't capture this data. Again, what is the cause of this? We have a problem of the cause of this because there is no post-mortem. Patient can die, but the cause of this may not be clear and no postmortem. So the study highlighted the shorter length of stay among trauma associated with worse outcome because the patients are sicker and need definite care or operation. Although short length of stay has higher mortality, it is not independent predictor. On the other hand, prolonged length of stay has better outcome due to less injury and stability, but this patient has a burden on the ED, the availability of bed. So we have to address also what to do to shorten the long stay to make the flow easy in the emergency. And thank you very much.
Thank you so much, Doctor. And I'm honored to introduce the next speaker, Dr. Anwar Al-Awadi, who is a specialist in emergency medicine, emergency medical service, international disaster medicine, public and global health.
Thank you. Thank you. Okay. I'm sorry. No. Sorry. Hello, everybody. I know it's late. It's the last lecture. We try to keep it simple. But this talk is basically on trauma, and it's actually the serum markers that predicts brain death due to trauma. So we all know that trauma actually is a burden to any given society, and it's a multifactorial, and it can lead to quality of life loss, finance, and it could be devastating, especially for people who support more than one family. So the statistics globally about this is actually trauma is the leading cause of death below the age of 45 or 46. We all know that the leading cause of death globally above the age, let's say, of 70 or 80 is actually cardiovascular than cancer, but trauma specifically below mid-40s, which is a major thing. The statistics on this is actually as we describe, road traffic accident kills actually 1.2 million annually. And 90% of those are, middle to low income. The estimated global cost to this is actually north of 500 billion globally. And actually, this is the most important thing, which is, it's predicted to become the third largest contributor to global burden of diseases. Something close to the NCD, non-chronic communicable diseases. Now, in terms of quality of life, you can see here that you can see here that it's actually almost matching the cardiovascular disease when it comes to quality of life, because if you're disabilitated, if you have loss of ability to make an earning or take care of your family, it's a major thing. And in the United States, the numbers are close to 3.8, actually 4.2 trillion. Medicare, which is the the social welfare health system over there, spends north of 300 billion on that. And work loss is major, also 70 billion. So not only the employer but also the employee loses productivity when people experience trauma. Now, TBI, or trauma brain injury, also in the United States, is estimated around like 1 million people, 30,000 hospitalized, 50 deaths, which actually accounts for a third of all trauma. So brain injury is a major cause for such effect on the any health system globally. Now, these are the basic signs and symptoms of head trauma. It actually ranges from mild to moderate to severe to debilitating or actually vegetative states. But the major points that we have to take today is actually history and clinical criteria is one of the major elements when it comes to this. So if somebody who is persistent coma, obviously off sedation, so he's not sedated, like with a history of major injury to the brain cell, absence of brain reflexes will go through that, and lack of ability of independent breathing, again, off sedation. So basically, NHS, classify it as unconscious and fail to respond. And then there is no heartbeat or breathing when you disconnect him from ventilator, and there is a history of a clear severe brain damage to that. And obviously this is like divided into cerebellum and brainstem. So brainstem for the reflexes and cerebellum for the cognitiveness. Now, is also radiographic adjunct tools that you can use to be a surrogate for brain death. So you receive a patient, physical and history, and then you do all the adjunct like CT, MRI, Doppler, or angio to look at that. So you look for diffuse axonal injury, all types of bleeding, like subarachnoid, subdural, and all that. Now, other stuff you have to take into account. So you cannot call somebody like brain death unless you rule out that there is no overdose or any chemical agent or severe hypothermia or hypothyroidism or any other illnesses that actually blunt the brainstem or the brain function to be examined. Now, the test that you do at bedside is actually, the one that you do every day when you have a severe trauma and when you wean the patient off sedation. So consensual light reflex, corneal reflex, caloric reflex and stimulation, gag reflex. If you discontinue the patient from, again, off sedation, but discontinue the patient from a ventilator and add a catheter with the oxygen, and if there is no gag or cuff reflex while he's off sedation, that's also a hallmark for that. Now, some patient might have some spontaneous movement of the limbs. This could be a spinal rather than, a cranial element. So we move about the topic now, which is what is the serum biomarker that can help you to actually not only diagnose but actually predict the outcome measure for such patients. So there are more than 20, but we will focus on 6 because these are the 6 biomarkers that have been running around in the recent studies in the last at least 5 years or so. So the abbreviation is actually between brackets. So you have the serum calcium binding protein, GFAP, and then ubiquitin and neuro-specific enolase and tau and neurofilament. The most important thing about these biomarkers is some of them actually interrelate between other tissue. So let's say cardiac cell or muscle cell or spinal or bony or actually cerebral cells. So once they cross, you have to know their origin. So if you have a biomarker that originates from a specific, let's say, type of cell, and you have a patient with polytrauma, you can actually, not misdiagnose, but rather misinterpret the result. The reason why all these institutions, when they run the biomarkers, they run them on automated, graphs, so they can see the trend up and down. But the most important thing you need to know about this is the half-life. So what's the half-life when time zero when the patient come in? What's the half-life in a few days, in weeks, or even months? And you need to combine also these with other prognostic factors. So for example, the ubiquitin, the S100 protein or tau, they have half-life of hours. While, for example, the neurofilament for weeks. So you just need to learn about these biomarkers, where they originate, what's their half-life, and what cell line they come from in terms of injury. Now, as we discussed, the other things that could affect this is actually polytrauma or, let's say, hypoglycemia at the scene, or hypovolemia, or even cardiac or respiratory arrest, which is probably no trauma, is just like cardiac or respiratory arrest with brain anoxia. So you have to find out the cause so you can learn about these markers and where they're originating from. This is one of the studies that looks at these biomarkers, and the conclusion of the study, they actually, this was published in The Lancet, they looked at if you use these biomarkers together, they give you a good predictive value for risk assessment and the unfavorable, let's say, prognosis. So you can have a resource reallocation, and instead of, let's say, for example, waiting for a patient for a long time with aggressive, intensive care. So another study also looked at. We'll show you the diagram for all these depiction for the trend for all these biomarkers, the half-life, and how they perform. But in general, the recent studies in the last 5 years, they all look at these biomarkers, whether used individually or combined, and how they actually enhance the predictive value and the prognostic outcome and resource allocation. And this is actually some of the trends, so you can see it. So you can see the decline and then the decline of all the biomarkers, and how, with time, depicted with time, how is the patient is improving clinically. And obviously you want to use also radiological or some lab test or clinical bedside testing, just to combine all of this to have a proper prognosis for these. As we described, like some of the tools that you have to use is probably CT or MRI or EEG, and most of these studies also combine something called Glasgow Coma Scale at the scene, but then Glasgow Outcome Scale as the patient is in the hospital, and they use something called Glasgow Coma Scale Extended, which is for a few months, and this is how they risk stratify those traumas and they predict their prognosis. They also combine them with something called, the abbreviated injury scale, which is 1 to 6, like mild, moderate, severe, or all that. Injury severity score, which is 1 to 75. And the new injury severity score, which is the sum of a square of the 3 major injuries. So they depict all of these, scan, clinical, and some of the data, and combine them with the biomarker. So, so for the long term, once your biomarker are trending down, you want to know how is the patient's doing. The Glasgow outcome scale is actually divided into those categories from mild to moderate to severe, so you can combine them with the biomarkers to look at that. So in summary, biomarkers are very important, but also don't forget to use, your clinical judgment from history, physical examination, and radiological finding. And if you combine them with the biomarkers, they help you to have an advantage over risk assessment, your stratification, resource allocation, and prognostic values. Thank you.
Thank you so much. I suppose right now we have time for questions. Anyone? If not, maybe I will start, because I have questions to Professor Carlos. Because we know that this year was published the International Trauma Life Support Guidelines, and I'm of course agree with this, that we should perform restricted fluid resuscitations among trauma patients. But according to your presentations, you says that we should give the 1 gram of tranexamic acid with the windows of treatment of 3 hours, and then 1 gram in the fluid, in the continuous infusion. But I'm asking you, maybe in your perspective, this is good way to start, for example, giving the tranexamic acid even in the EMS, in the pre-hospital setting, or we should wait till the emergency department?
No, thank you for the question, Luska. No. I agree. Most of the good results start on the way of the hospital. They start on site of the pre-hospital care. They give the better result. And one of the slides I show you is, as soon as you can, they start the medication. In the paper that they wrote, they show that the benefits when you start right there in the pre-hospital care.
Thank you so much. I am asking because I read the article in which author state that we should even give the first dose in first 10 minutes. So I am asking the specialist. Any other questions? So maybe I have one more question to the last speaker, because you talked about some specific markers, but in your perspective this way, after injury, in which time windows we should collect those samples to examine those markers to make sure that the markers has good predictions in brain death.
Right. So we had the slide on the half-life of the markers. So you would look at, for example, time 0 when the patient arrived to the hospital. So you collect, let's say, the 6 of them. But then after you target the half-life for follow-up and prognosis over hours, days, and probably weeks or months, you have to know that table, which is the half-life of these markers. Because some patient might have, let's say, a prolonged axonal or hemorrhage or brain edema or even midline shift, and they, with the with the management, they could improve. But the only way to combine this is actually with the markers half-life, basically.
Okay, thank you so much. Do you have any other questions from? Okay, so thank you so much for this session. It was really a pleasure to listen for me. Right now, I suppose we finalize today's day and we will meet tomorrow. So thank you so much and have a nice evening.